Labrīt!
Good morning, dear conference guests, Mr. Minister, Excellencies, guests from foreign countries. We are gathered on the right time and place. My name is Mārtiņš Dauguls. I'm from Rīgas University, and this is a right time and place means that the conference with the name krīze, crisis in the healthcare human resources. It's not just a beautiful name, but that's indeed an issue. We want to look for a solution for it. And we talk about the times where not just in Latvia, but in the Europe as whole happen a lot of intensive discussions how to finance certain industries, where to direct priorities, and Latvia is not unique from that standpoint. When we talk about defense issues, how to support them, and how to keep the growth in the healthcare industry. And one of the topics you will hear many times today, and for me it was sort of a discovery, we will talk about the medicine deserts. When we talk about the deserts, we speak about, we take a term from environment. It means that there are locations where there is no healthcare available because there is no human resource to provide this. And how to fight against this erosion of our medicine landscape, how to work with it. One thing, we will gather our knowledge, and not just internally in between our industry, but we also will speak with different industries like Confederation of the employers, but we also will speak about the collaboration on the European level, Union level. And that is a first-time event in that high quality in Latvia. And second, we will follow the whole life route of the person. We talk about the healthcare patient-oriented. But now we are more directing towards human-centered orientation, and including all the healthcare personnel. The conference will be in 2 languages. We constantly translate all the content, and there will be a video address from the Prime Minister of Latvia, Madam Evika Siliņa. Honorable guests of the conference, as the base of the healthcare are the humans working in the industry. Each employee is a value, and it's very important that you are here. The healthcare policy, international experts, the lack of human resource is one of the biggest challenges for the industry, not just in Latvia, but in Europe as a whole. It's also affected by the demographic changes. The society grows older, and it's not just the statistics, it's also the exam for our values. A lot of things happen in the modern days, but in medicine, it cannot happen quick. To become a good medical specialist, you need to be trained, you need to practice a lot. New specialists need just not that competitive salary, but also the work-life balance. Therefore, it's important to have a motivational environment and the opportunity for those to return who have chosen to work abroad. We have worked a lot to support the GP practices. We have created special programs in the regions. Just recently, when this government started, healthcare was a #1 priority in our budget, and we haven't forgotten about it. Therefore, the state continues to invest in the healthcare, in the quality of the work for nurses and other healthcare support professionals. I wish you courageous ideas and a lot of inventions. Thank you, Mrs. Prime Minister, for the opening address and for the courageous ideas and inventions and solutions. And now I invite on the stage Mr. Hossam Sabu Meri, our healthcare minister. Good morning, ladies and gentlemen.
From Montenegro, from Cyprus, from Lithuania, from Estonia, from Malta, from everywhere. So I'm going to speak in Latvian because we are in Latvia today and would like you to hear the Latvian language and especially my accent in Latvian. So, mani kolēģi.
Dear colleagues, ministers, ladies and gentlemen, friends, our collaboration partners, first of all, thank you, Mrs. Prime Minister, for an inspiring address, because indeed, the healthcare in the recent government is a top priority, and we hope it will remain the priority. It's a true honor and satisfaction for me to speak with to you in Riga in the international conference that is dedicated to one of the main important pillars of the healthcare system. It's our human resource. We are all representing here different countries, and we know that healthcare is impossible without a human resource, without doctors, nurses, caregivers, pharmacists, and support professions. They are all in the heart of the healthcare system. But unfortunately, the heart today is overloaded in its rhythm. And such heart, if it would be a human body, would need a cardiologist's assistance. Latvia is facing similar issues as Europe in general. Insufficient number of personnel, growing older in average numbers, insufficient personnel availability in regions. 2 days ago, I was in Latgale region. We had a big meeting with our municipality leaders, with our family doctors representatives. And we were talking about the challenges how can we involve new colleagues outside the big cities, also in small towns. And it's a big challenge. Particularly Latgale, because Latgale has a huge border with our aggressor neighbors, Russia and Belarus. And people who remain living there, we need to take care of them. Because if we want to say that we will stand and protect our country, we need to remain in where we are, so that our citizens will stay in where they are. We need to take care of them, both from medical standpoint and education and other things that are necessary for them to feel, to live a full life in their locations. The number of expectations of our population increases, and the number of those who work in a healthcare industry is dropping. Therefore, we need very clear plan for tomorrow's solutions. If we postpone them now, it might be too late. And now it's a time in a healthcare to stress out that it's a national security issue. Healthcare is an issue for the national security. It's an issue of European security. It cannot be that on the times when Europe healthcare is in such an unstable situation that we decrease the financing. We healthcare professionals are similar to our police employees, to our fire and special professionals. We all are crucial for sustainability of our country, for the survival of our countries. We know that artificial intelligence can be a big support for us, but the technologies cannot replace human being. It's easy to use AI, but AI is not a human being. We need a physical contact with people. It can be an efficient tool for an individual patient to appoint the most precise treatment, but only when we have a personnel that's been trained and knows how to use this kind of tools. We not only need more personnel in our system, we need to change our thinking way, but we get more flexible. We need to have more collaboration models with the social industry, increase the role of primary healthcare, more healthcare in the regions where people do live. Because base of everything, foundation of everything is caring about the human. We are having a lot of discussions, which hospital is more financed, which less. But after all, we are all helping the same human. I really believe that every crisis is an opportunity. We shouldn't say, okay, it's a crisis, everything is too bad, let's go home. Indeed, that's why we are gathering, to see, to work on new solutions. We see that health mobility is a new reality. And I see an example that we small countries can compete not only about the talents, but also show an example of efficient collaboration. Here we see efficient collaboration of the small European countries and how we can sustain against in relationship with the big countries, how to resolve the issues when our patients are waiting in a long queues to get the solutions for the health issue. Therefore, we in Cyprus, in Lithuania, Estonia, Monaco, Luxembourg, Montenegro, we are joining to be together, and we have people in our countries who also need healthcare and support. Therefore, the collaboration of small countries is really a great initiative. And I know that today we can exchange our experiences. It's very important for me to hear the experience of Montenegro, of Cyprus. That's why our guests are here in the conference. We have to look for joint solutions, both regionally and across the borders. Dear colleagues, friends, we are all in the same boat, and the world is getting smaller. The world is not stable these days. It's a crazy time now. In the morning, we wake up with one decision. In the afternoon, before the lunch starts, we have to make few more decisions. And before we go to bed, we again make new decisions. And at night, dreaming, we see yet another big decisions to make. This instability is really challenging our quick reactions. And it's challenging not for us like a government, like politicians, but for all society altogether. In our hospitals, in pharmacies, in family doctor practices, in nurses, everybody who joined here in this hall, we are all in the same boat. And if we will collaborate, we can move on. If I will try to row my boat forward as a captain, and one in the boat wants to turn left, one to the right, and one to stand on the same spot, the boat will get stuck. I do believe that we will succeed in our efforts, because our common pursuit is the same, to provide a healthcare system that can serve a human. Any situation, any location, any time. And indeed, I believe that our common reactions and collaboration is a main power. Thank you very much for your attendance and for you being ready to create together a future of healthcare that is based in human resource, who feel strong, protected, and knowledgeable. Let us all have a fruitful and productive day. Thank you, Mr. Healthcare Minister, Mr. Abu Mary, who will also join us in a panel discussion with other healthcare ministers in a short while, and for the final, for the closing address. Indeed, the topics mentioned are in our agenda, and next addressing speaker is a World Health Organization European Directorate head.
Labdien and warm greetings from Copenhagen. Over the past few weeks, more than 5,000 people have engaged in discussion on issues shaping the future of health, from digital health and green hospitals to primary care. If there was one thing that stood out during WHO Europe's public hearings on the next European programme of work, it was this: health and care workers are key to every aspect of healthcare. We need health workers to deliver essential services to aging populations, to reach remote communities, to provide human care despite the benefits of digitalization, to ensure countries can respond to health crises. Investing in health workers means investing in the future, reinforcing national resilience. Ultimately, it's about serving the people. Today's conference is yet another testament to Latvia being a health leader. Latvia faces unique challenges as a small country, but small countries often lead by example, driving innovation in ways that larger nations can benefit from. Latvia sees investing in the workforce as a national priority, despite an ever-changing geopolitical landscape. Latvia stands out with one of the highest response rates of European Union countries to WHO's first ever survey on the mental health of doctors and nurses. Latvia is an active participant in the new Nursing Action Initiative to tackle critical shortages in the EU nursing workforce. And Latvia has adopted the Healthcare Workforce Development Strategy 2025-2029, mapping a future direction for human resources, staying on the path of building a strong, sustainable workforce. So Latvia has made health workers a policy priority through WHO Europe's Small Countries Initiative and its Human Resources for Health network, supporting the adoption of the Framework for Action on Health and Care Workforce. I will close with the words of one of Latvia's most renowned poets, Imants Ziedonis. Laiki nav svarīgi, svarīgs ir cilvēks. Times are not important. What matters is the human being. A warm thanks to my respected friend, the Minister of Health, Dr. Hossams Abu Meri, for your regional and global leadership, but also thank you to your very committed team. It's such a pleasure to work with all of you, and rest assured you have WHO's full support. Thank you and good luck.
Sirsnīgs paldies un aplausi klūgu.
Heartfelt applause. And this event is supported, and in the same idea space, we have a representative of European Union Ambassador, Madam Petri. Good morning, honorable guests, excellencies, ministers. It's a big honor for me to be part of this high-level conference that is addressed for the healthcare human resources crisis, and to see such a wide range of the political creators from our closer and further neighbors in Europe. We live in the era of deep change, and it affects both our society, our security, the economy. These changes are affecting everyone. Also, the healthcare industry is really facing great challenges. We see how the demography changes, the society grows older, and that increases the demand for the healthcare services. Chronic diseases expand. Healthcare expenses are big and growing. We face a lack of critical medications, and of course, we face a lack of medical professionals. Thinking about these challenges and changes, the minister already mentioned that we are in the same boat, and Europe together has to be able to navigate through those stormy waters. And to do so, we need to have a right strategy to see that ourselves stronger after the storm is over. The policy for 2024-2029, European Commission President von der Leyen has set several targets. Moving to the health, to create a health union, diversify the supply chains, to provide access to the most modern treatments, create sustainable, resilient healthcare support systems, and create enough medicaments, and also give the space for the innovations. If we look on the mandate for the first few months of the Commission, we see exact steps in the health care area. There is a new EU regulation from March, which allows us to exchange data, and it from that benefit everyone, patients, healthcare providers, and innovators. Further thinking about the data protection of our patients, there are new developments for the data protection, and also the biodata, work with biodata. This is time when we need to invest in innovations. It's important for support of the competition force of Europe, and at the same time to resolve the issues that healthcare industry is facing, including the human resource crisis. But of course, the healthcare professionals are indispensable. Recently, there was a report of EU Commission and OECD. We see that in EU, there is a significant lack of healthcare professionals. We talk about 1.2 million medical professions. Of course, situation in each country is different. And also within the country, it's distributed differently. Also in Latvia, these indicators not make us happy. To resolve this issue, we need to multidimensional approach, which is relevant for each country's relevant situation. Some of the elements is a necessity to plan the human resource, to support the policy, making of the policy decisions, political decisions about training new doctors and nurses, also the use of innovations to support the productivity of healthcare professionals. From the Commission side, it supports the EU members, different initiatives of those, to integrate the healthcare professionals in their national strategies and wider reforms. Also, there is a line of initiatives regarding the skill development and the EU for Health program. However, on the state level, there is a support through the European semester, where the member countries get recommendations how to adopt these programs for each state challenge and to reform their health care systems, and also the financing.
That is devoted to development of the health industry. From the European Union funds, in the planning period until 2007, and also through the recovery funds where investments are available to the healthcare system. I think that we are happy to see improvements in the infrastructures of hospitals lately, but within the plans of recovery in Latvia, also for mapping, for human resources and strategy development in the healthcare industry, for which the agreement was reached already at the end of last year, and from European Social Fund Plus. Additionally, there's funding intended for specifically for events with the aim to attract and maintain, keep the personnel in the healthcare industry. These are just a couple of examples. However, it is very important for these opportunities to be used. It is clear, at the end I would like to say that we need a lot more to do, a lot more needs to be done in Europe and in Latvia. We need a strong basis of Europe, which is healthcare industry. I wish you fruitful discussions, and I wish you to be able to combine all your knowledge and realize the plans which you have for the next steps. Thank you.
Sirsnīgs paldies Petras kundzei un Eiropas.
Thank you, Madam Petre, and also representation of the European Commission in Latvia. As mentioned by the Minister, Josep Abumeri, we are today broadening a scope, and here the healthcare industry can see that it is a matter of the national security. So that is why Anatolis Kutsevals, Ambassador of Ukraine in Latvia.
Ministers, dear representatives of small but great countries, and ladies and gentlemen, dear friends, for me today is an honor to be here and to speak to you and also to address. I'm really grateful to Minister Josep Abumeri to also to mention the need how to use the crisis. Ukraine is in crisis, I do believe, at least for the last 5 years. We also do count COVID crisis as one of the examples when we had to live through, and we also had to be stronger. I do believe COVID crisis also created some strengths for us when in 2022, with unprovoked aggression, we faced war. The war is something unbelievable. You might try to get prepared to it, but believe me, you won't be prepared. On D-Day, everything changes a lot and you just face reality. And reality is the following. All of us, we globally see that we have problems with the human capital, both in different areas, but also in the healthcare system. Ukrainians were the country of 40 million before the beginning of the war, then up to 7 million just fled country. And you see this is a human crisis for different areas, including healthcare. But healthcare also a challenge for smaller countries, for bigger countries. And first of all, I would like to say that with this 7 million, we also had Ukrainians who are medicians and who are also contributing to the country's development. And I do hope that they are also contributing to small countries' healthcare systems, along with the support which you are providing to Ukrainians. And here I would like to thank specifically Latvia for hosting more than 60,000 Ukrainians for the last 3 years, for providing them medical healthcare support. And it's not only about our wounded soldiers, brave soldiers who are coming here for rehabilitation. Those are immense numbers. Just to understand, it's a one-person life, it's something priceless. And when you see rehabilitation of one, you might see about thousands to be rehabilitated. I really appreciate our colleagues in Latvia for providing support for rehabilitation of more than 540 brave Ukrainian soldiers, men and women. Some of them went back even to fight. And this is a reality. So how the healthcare system is working. Some of them just came back to the system and trying to be people who would like to contribute to the development of the one country, but also bringing some experience back and also bringing some experience here and to all smaller countries where they go. This is a reality which we are facing. And all of us, we are facing the same crisis, both healthcare system, but also security crisis. We as a country, much bigger from the scale, I mean, not a small country, but also had a problem of having enough resources for the healthcare system development. From this point of view, I would compare us also with the small countries, with some small resources to invest in our healthcare system, but we still do it. And we do it with you, with European Union, with all countries in Europe, and we're really grateful for it. And it helps us to survive. And this is really important, and we need to think about that from that perspective. I do believe that our overall goal is to save human beings. And that is why, for that sake, we have Ukrainians which are right now fighting on the ground, including medicines, and they are under constant attack near to the front line. Our enemy, Russia, they are actually shelling Ukraine on a daily basis 24/7, no matter what is happening. And those are also healthcare institutions. Just to understand that since the beginning of war, we had like around 2,400 only shellings over the healthcare system, including one which did happen last year, and everyone saw it. It was a children's hospital, Ahmadid. It's a downtown of Kyiv city. And no one actually believed that it could happen in that way. All this causes human losses. We only lost around 240 Ukrainians being in the hospitals. We got around 800 wounded being only in the hospitals. You might see a lot of people wounded near the front line in different hospitals, in the issue of security. I do really appreciate what WHO does with all partners and what support they are providing. But the fact is the following. We have around 10 million Ukrainians which need healthcare in Ukraine, and we have around 10 million Ukrainians which need psychological rehabilitation. This is the outcome of the war. So how we need to prepare ourselves for the future as small countries, as a joint combination of all of us, is that we need to invest time, because it will be decades ahead of us to work with different people around the world, around the globe, to heal all of us from the consequences of war. I really appreciate that what you do, especially a special tribute to Latvia for providing support to Ahmadid, to Ukrainian citizens here, but also for Ukrainian medicines to continue working in your healthcare system. We really appreciate what you provide to Ukraine. I would like to use this opportunity. It's not a negative speech, believe me. It's a reality, and it's a time of crisis from which we need to get a lesson. And we also should be stronger. As I started from the very beginning, after COVID, we became stronger. I do believe after the war, we will also become stronger. The only thing which we would like to do is to be stronger with you, with all countries, no matter of the size, and also with Europe. And this is our key aim, a key answer to any threats which we might face in future and already now facing. Thank you so much. I do wish you to have a really good exchange. Thank you for organizing this event on behalf of Minister of Healthcare, Viktor Leshko, who was here yesterday and witnessing a good experience. My heartfelt thanks to all organizers and all medicians working in Latvia and all smaller countries, participants of the conference. Thank you so much.
Thank you so much to Ambassador Mr. Kutsevol. Thank you indeed. Un tagad, dāmas un kungi, mēs...
And now, ladies and gentlemen, we are changing the rhythm of the conference from the opening speeches and addresses and from highlights. We are moving on to the informative level and what is going on. And the first panel of the reporters is going to be about the structures, labor market, the perspective, how it is in Europe, and I'm mentioning also as it is like medical desert term will be mentioned, and also the employment and human resources in healthcare field. Francesca Colombo, Economic Cooperation Organization, and her report, OECD report.
Here today. So we spoke about we're all on the same boat, but we're actually navigating quite rough seas. So I'm going to make a presentation just giving you a little bit of a background on that rough seas that we are into. I'll start actually with COVID-19, which obviously has been a huge shock, but we're also facing a number of other shocks. Crises linked to, obviously, conflict, but also potentially climate change and so forth. All of those things are challenging the health system. This slide actually shows two variables. On the vertical, you will see the relative size of the health workforce in different countries. So that's on the vertical. The more you're up, the more you have health workers. And on the horizontal axis, you see excess mortality, and that's during the COVID-19. So the number of people that died, more than what would have been expected if we didn't have COVID, looking at what happened before. And what you will see, and in green, I put all the small countries. You will see that a majority of small countries are concentrated on the quadrant on the bottom right, which is where there have been more excess mortality and less health workforce. So that is really quite clear. Health professionals are essentials in order to prepare in case of a shock and of a crisis. But there are other things actually which are challenging the health workforce that we need to be aware, and it was mentioned, I mean, the aging of the populations. On the one hand, if you have population aging, you will have more people who are old, and so more demand for healthcare. In countries like Lithuania and Slovenia, there will be an increase in about 30% of the populations which will be over 65. But here, actually, I'm showing the aging of the health workforce, because not only we are aging ourselves, but our health professionals are aging. And you see two dots for each country. The dot at the top is the most recent, 2022, and the dot, which is for each country lower, refers to 2005. So for all the countries, the share, the age of the population is going up, and the share of doctors who are 55 plus is really going up. And you see there, again in green, Latvia and Estonia with nearly 50% of their health professionals being 55 and plus. Similar situation for health, for nurses as well. So we are facing a number of health professionals that will retire quite soon, and that points to the needs of doing a number of things. Obviously, I will talk about training more doctors and nurses, but also perhaps having more flexible retiring arrangements and ways that will allow health professionals perhaps to work a little bit longer. But that's the aging of the population. It's not just more demand for healthcare, but also fewer potential health professionals that will be there. Now, all of this, the need to have more health professionals because we're getting older, to face crises, and because some countries, like small countries, have few health professionals, will actually happen in the context where fiscal resources are very tight. So a number of the small European countries do spend as a share of GDP less than the European average or some of the bigger countries. But if you see all the countries following a spike in spending during COVID-19 are actually going down right now. To levels which remains higher than before the pandemic, but arguably not enough to prepare ourselves for future shocks, including the potential new pandemic, crisis linked to conflicts, as well as aging of professionals. So that's the landscape that we are. It's not super easy. We'll have more needs. We have a share of the population in working age which is decreasing. We'll have doctors and nurses who are aging themselves. So what are some of the solutions? Now, the first solution is obviously, let's train more. Let's try to recruit and train more health professionals. That's fundamental. Basically, we are not be able to cope with future demand unless we'll have more of those professionals. And to be fair, most countries have been doing that. Again, like on the left here, for each of the countries, you see two dots. And so you see the situation in 2012, and then the situation in 2022. So 10 years difference. And in all of the countries, you see that the dot actually goes up. So we are training more health professionals, and that's actually the number that is shown here really shows the number of medical graduates, so those who are coming out. So that's really, really good. But there are still some challenges, and show on the right, for example, in terms of nurses, that for Latvia, actually the number of nurses graduates, it's going down, and for the European Union and European countries as a whole, it's actually quite flat. So, you know, we need also to think about the nurses, other type of health professionals. But at least that it's a good news. Perhaps more challenging, actually, and I'll walk through this because it's a very packed slide, but it's actually the interest the young people have in becoming a nurse or a doctor. So these are actually data for all the different countries. Again, in green are some of the smaller countries. In terms of interest by young people, so this is from data from PISA, which is a survey the OECD does on young people. And they ask them, like, what's your aspiration for the future? What do you want to do? And again, 2 dots here. We have the diamonds, that is the more recent one, and we have, sorry, the oldest one, and then we have the more recent, which is actually the bar. In most of the countries, the interest from young people in medicine and in nurses is actually going down. So you have the bar, which is lower than the dots. So that tells us that young people actually tend to have aspiration to go in different jobs, and mostly in the digital area. So we have an issue of making sure that the attractiveness of working as nurse, as doctor, remains high, both in terms of an aspiration, as well, obviously, in terms of their working condition and so forth. So that's something that we need to do. Yes, we need to train more. We are doing quite a lot, but we also need to work on making sure that young people also will want to choose this profession. And so retaining talent becomes a fundamental issue. So we need to attract young people into the profession. And then once they get there, we need to keep them, and we need to make sure that the working conditions are attractive. And here, I want to show just one element of working conditions, that's the remuneration, and here in particular, remuneration of nurses, hospital nurses. Now, what this graph shows, it's salaries. It shows the salaries relevant to, on the left, relevant to the average age in the economy. So for those green countries who are below, it means that the salary for nurses is below the average wage in the economy. And on the right, you see in, if you want, in absolute terms, but adjusted for difference in ability to pay, in purchasing power across countries. So so it shows that in a number of countries, actually, the remunerations for nurses is actually below the EU average, and that obviously it's one element. It's not the only element, but it's one important element of the attractiveness. Now, a number of countries actually rely on foreign trained, in the case I'm showing from doctors. The question mark is this a long-term solution? Like here again, we saw 2 points in time, 2012 and 2023. A number of countries, the bar go up, so more reliance on recruiting from abroad, particularly from non-small countries, but also some of the small countries. There, Estonia, for example, has increased the number of health professionals. The question is reliance on recruiting from abroad an equitable as well as efficient long-term solutions? And say equitable, obviously, because most of the countries that lose their health professionals are poorer countries. They can be small, they can be big, but generally they're poorer. And most of the countries that attract health professionals tend to be of higher income. And so it's obviously not equitable to rely on other countries which are trained as well. It's also not efficient if we know that in the long term there will be so much more need, so countries need to train more by themselves. But clearly there are some net losers and net winners in this migration of health professionals. Here, just showing the example of Latvia, with just the sheer number of immigration of foreign trained doctors to Latvia, and the number of those who are emigrated. Here the balance is negative, so you're losing more then you're actually able to train. So some countries are net losers, and that's something that must be addressed internationally, obviously, by making sure that things like the WHO codes of ethical recruitment is abided to by all countries, and domestically, obviously, by keeping on improving those working conditions that I was mentioning. But I think another very important point that I would like to mention is the issues of productivity and innovations. If we want to face up to the future demand that will be quite high because simply of aging of the population, but also preparing for future shock, we need to become better at improving the productivity of the health workforce, and that's more difficult actually to achieve. But to illustrate why this is so important, I wanted to show you this graph. It shows on the top line the EU populations age 65 plus, so in millions, and they show it historically, where we are now, but also projected into the future, the bottom line, the dotted line. And on the bottom, you see the total employment actually in the health and social care sector, which is actually going up because, yeah, countries are making efforts, but you clearly see the gap. The age population will be so much more compared to even all the efforts that we're doing now. And we're doing efforts meaning that the share of people employed in the health sector out of the total working age population is going up. So we are actually trying to get more workers from other sectors, which raise question, will this be sustainable in the longer term? So if we continue going ahead, we might actually not, even if we train more and more, we might still face with a gap. So that's why the issues of productivity and innovations become very important. So what could be the possible solutions that we have? One has to do with skill mismatches. Difficult concept to explain, but essentially we have surveyed, through a survey the OECD has, both doctors and nurses, and asked them, do you have the right skills to do your job? And a good majority, the blue ones, say, yeah, we do. But actually we have a significant, and that's in orange, share of doctors that say, I'm actually underskilled. I don't have the skills, particularly digital skills, but also skills to manage complex relationships with patients that allow me to do my job at the best, to improve that productivity and ability really to deliver to the needs of populations. And on the other hand, you have a quite large share of nurses, and that's in green, that say, actually, I'm overskilled. I could do so much more. And so that points to the fact that perhaps we need to redistribute the task. Perhaps we need to think of roles of nurses, but also of physician assistants, other type of health professionals that could do some of the tasks and free up the time for those who are trained for longer, nurses and doctors, to do more complex tasks. The other issues of increasing productivity has to do with using, and it relates to that, non-physical staff, non-physician staff. Here it's the results of a survey that we just did, asking patients themselves to what extent they have other professionals, primary care, like non-physician staff that works with them in primary health care. And we see that some of the countries are doing quite well, Iceland, Slovenia, others perhaps like Luxembourg a little bit less, but also in terms of using electronic medical records to support their practice. And we see that a number of countries on the right here, still have a margin to use those data better to improve the care. Other things, and I know it was mentioned, artificial intelligence will not be a solution for everything, but actually there are things that it can do quite well and help. For example, various surveys and research has shown that 30% of administration tasks could be automated. Think if a doctor didn't have to do all those administration tasks, or could do it in a much faster way, and the same also for nurses. That would be really like a way to free up space just for care. And we have done a survey of health professionals, asked them their attitudes and what they think about artificial intelligence. Most of them are not worried that they will be replaced by an algorithm, but they are actually worried that those algorithms, those artificial intelligence are being developed without them. So that's fundamental. If we want really to improve that productivity and efficiency and so forth, we need to make sure that artificial intelligence is developed with the health professionals, addressing really their needs and what it's most important for them in their daily job. Last thing I wanted to see on improving productivity has to do with work organizations. This is just an example of Estonia, which has been quite successful in leveraging more the use of family nurses. They can do a lot of tasks and activities, as put on the right. Bottom line is that we need to think perhaps a little bit different from the model that we had, what the doctor can do, what the nurse will do. We need to be a little bit more innovative, use different type of health professionals, perhaps people who require training for a shorter period of time, rearrange the care and the task in different ways. That will help us tremendously to raise the productivity and face the huge demands that otherwise will be different to face in the future. So just to sum up, clearly we need to train more health professionals. COVID was very clear in this respect, but it's not the only pressure that we'll face into the future. And we must do better in increasing their attractiveness and retention of health professionals. Job quality will be fundamental here. It's not just about remuneration, that is important, but it's also about the quality of the job, making sure that health professionals are not overwhelmed and by the tasks that they need to do. But we need also to focus on those innovations, thinking about different categories of health professionals, thinking at how health technologies can complement, be developed with the health professionals themselves. And that hopefully will put us on a much better ground from the future. Lastly, of course, we do want to learn from each other, and conferences like this one, it's really very welcome. I look forward to the discussion, and thank you again for the opportunity to address you today. Oops.
Thank you very much, Madam Colombo, and
Very
insightful numbers and trends we can experience. A lot of people were making screenshots and pictures from the presentations. Just for information, then this is, as the representative of Health Minister said, the Bible of statistics in this field. So you can definitely go there. But also all the presentations from the conference will be in condensed and framed way, foundable in the homepage of Ministry of Health of Latvia after the conference. So it's place to return after that for more ideas. Thank you very much. Mēs šobrīd pievēršamies
Now we move to the employment from the Latvian standpoint, how the employment is following the general tendencies. Juris Mazās, Parliamentary Secretary of Ministry of Economy. Good morning, Mr. Minister, dear guests, excellencies. Firstly, I would like to express a big gratitude to the previous speaker. My presentation will be more like continuation about different ways how we approach and identify the future issues to work with them preventively. We need three big changes. The previous presentation showed those three negative tendencies. Those are related both to demography, to education, and us as aging of the population in the country. The development of the economy since 2020 lived through not just COVID. We had several big events, and it affected both the migration and the health of the population, and also the birth rates. And as I mentioned, we need to change several tendencies so we can grow our GDP. Ministry of Economy last year made a really ambitious targets about doubling the GDP and increasing the general quality of life in Latvia until 2035. And people may say we are too ambitious or something is unrealistic. For Latvia, as a quite small economy, there is nothing unrealistic. To achieve high results, we need just a few success stories. That, for instance, was in our neighbor country, Skype in Estonia. Such a level birth of unicorns, 1 to 4 unicorns for our country, and our GDP numbers are significantly improved. But now we come to the section, which is the model itself. What exactly we can do? We have to orientate our economy for the export, also in the healthcare industry, how we can export our services. We are a bit exporting our human resource with a high knowledgeability, and we are losing them for ourselves, and the saldo is negative from our standpoint. But here we have to think in the terms of the industries that hasn't thought so much about the export markets, and here we have to include them. The good thing is that this industry is responding to all the most modern criteria of the industry. We have also different supporting programs, both in digitalization. Maybe they are not directly directed to the internal market issues, but they are oriented to the fact that the enterprise can provide their services both in the internal and external market. And as you saw previously, we are facing such an important factor that we as a society are aging, and that makes an extra pressure on our labor market. And of course, all the areas are in competition for the new specialists, new brain, and there are a few choices we can make. Either we work longer in our life, later in our life, or we look for the resources outside the country, which is a migration. Either we try to re-qualify existing workforce, but it's still the inter-industry competition. Our next big challenge, if we think about the workforce available to us now, we see negative tendencies on the common description of the healthcare professionals, including the age of the healthcare professionals. The society is aging, and there is bottlenecks appear in the healthcare industry that negatively affect the rest of the system. Therefore, we need several breaking points. Well, actually, we need a positive change of the trend, the breakage of the trend. In the healthcare industry, according to our methods, we see the age groups are 55, 59 years old. They are potentially that workforce that will soon leave their work position. And in healthcare industry, those tendencies are really frightening, because the workforce majority, well, not majority, but a significant share have reached an age where to train new ones takes more time than for them to wait for their retirement age. But as a Ministry of Economy, we actively work on a silver economy development, or so-called, which is not an increase of the retirement age, but make more motivational measures so that those people choose to stay in the labor market, that they improve professionally and they have this lifelong professional life. And in healthcare, it will be a very important thing to focus upon. And we get an extra time to train our new professionals. What we do see, we have a significant deficit in those healthcare service providers. One of the big challenges, as I mentioned, as the previous speaker already mentioned, there is a doctor division and healthcare staff which can quite successfully train, for instance, nurses, hospital nurses. The training period is relatively short, so we can re-qualify existing workforce and provide it where there is a high demand, and relocate them for where we have overproduction of the workforce. But it doesn't resolve an issue of deficiency in count of doctors, where the training period is very long, and we have to face the truth that those people who honestly are still in their high schools, the competition will be extremely high, because basic knowledge is the same like in physics and others. And all these competitions, all these industries are competing for these high school students in the future. And we as a country need to work a lot to provide a competitive remuneration in the healthcare industry, so that those young people who are still in their school to show opportunity to work in the future in healthcare and earn good money doing this job. In general, I wouldn't like to say everything is too bad, but there are challenges indeed. And the good thing is that as a state, we provide several programs. We are developing several planning documents where we address those topics in both in the middle and long term. But also we have to seriously think about attracting of workforce also from abroad, so that we can change the saldo other ways. We will see numbers that professionals trained in Latvia choose the neighbor countries with a better salary, because there's a free movement of the workforce in Europe, and everybody in the competition about this. These tendencies are Latvia is sharing with also with the rest of EU. Thank you. Thank you, Mr. Mazās, Parliamentary Secretary of Ministry of Economy. And our first block of addresses is finalizing by the President of European Doctor Committee, Mr. Bakke.
Welcome with applause, please, at this particular moment.
Dear ministers, distinguished participants, guests, dear colleagues, thank you very much for inviting CPME to speak at this high-level conference on human resources for health. And we are pleased to be here, as tackling the health workforce crisis is CPME's #1 priority. For those who do not know our organization, CPME, the Standing Committee of European Doctors, is a non-for-profit organization representing national medical associations across Europe. We are composed by the 37 most representative associations in the EU, UK, EFTA, and Western Balkan countries. We cover more than 1.7 million European doctors. Here you see the photo of our new board, elected last November, in office since 1st of January. In reflection of the experience of the COVID-19 pandemic, which showed the value of European solidarity and joint action, and with a view to present and future challenges, CPME has reflected on key lessons learned and the future messages to European policymakers. We have summarized these in a health check for Europe, in which we present our ambitions for the next European Parliament legislature to continue building the European Health Union. As I mentioned earlier, tackling the health workforce crisis is CPME's #1 priority. Holding dialogue with EU institutions and policymakers has been key for CPME to advance the issue on health workforce. And in March, we brought 30 national medical associations to the European Parliament to bring forward the experiences of doctors with the health workforce crisis to decision makers. We looked at the impact of shortages and working conditions and heard experiences from various countries, including the opportunities and risks faced by smaller member states. The conclusions of our meeting showed that across the different healthcare systems, these problems are shared and action is needed how to tackle the workforce crisis. CPME workforce activities in the past. As a central dimension of our activities, European doctors have a long-standing policy strand on the medical workforce. Previous initiatives have looked at recruitment, ensuring safe and lawful working conditions, and high-quality training. At European level, there were also projects on workforce planning, an action plan on a continuation project aiming to create a community of health workforce experts to continue activities. We have also collaborated with our sister organizations on the issue of violence against doctors and have shared a joint statement calling for national authorities to take measures to protect doctors. In our policies, we stress some key points. Healthcare professionals are the backbone of the entire health system. Without them, there is no care delivery, no patient care, and no universal health coverage. Excessive workload, violence again, and verbal abuse towards healthcare professionals is rising with devastating consequences for their mental health and physical health. Our Latvian member, the Latvian Medical Association, reports that 82% of healthcare workers in Latvia are women, with many of them having experienced personal or at least emotional violence. A vicious cycle of workforce shortages and detrimental working conditions are risking patient safety and diminishing the attractiveness of the medical profession as a lifelong career. All countries are affected by shortages, ranging from shortages in certain medical specialties, especially primary care, or severe geographical imbalances, to unstaffing across entire healthcare systems. In many countries, the workforce crisis predates the COVID-19 pandemic, which only served to further exacerbate existing shortages. Recognizing the significant link between doctors' well-being and high-quality patient care, CPME adopted a policy in November 23 on well-being, which underlines our call that doctors deserve working conditions that are not only legally compliant, but also promote their well-being. Our policy makes several recommendations aimed at the EU, national authorities, and healthcare institutions with a view to improving doctors' well-being, including implementing interventions to improve working conditions and ensure a safe and secure environment. We also call upon member states to diligently oversee the implementation of existing legislation, such as the European Working Time Directive and Parental Leave Directive, and ensure improved compliance. National authorities must provide adequate funding for the medical sector and address the administrative burden on healthcare professionals. Dysfunctional digitalization and poorly designed digital systems often increase administrative burden rather than easing them, ultimately limiting or even reducing the number of patients a doctor can treat each day. As you heard here, I'm not the only speaker having this point today. When there are not enough doctors to meet patient demand, the remaining workforce faces excessive workloads. Overworked doctors experience both physical and mental exhaustion, leading to burnout, which is a leading factor in doctors leaving the profession. Implementing safe staffing levels is necessary to protect doctors' well-being and ensure sustainable health care. Earlier this year, CPME also adopted a joint policy with 8 other European medical organizations, calling for adequate management of staffing and workload, improving working conditions, and investing in education and training. CPME and the undersigned organizations affirm that immediate and coordinated action is needed to tackle the health workforce crisis. Turning to the issue of medical deserts, we see that this exists in many countries, both large and small. Here, it is not only about rural areas, but also underserved regions, including, for example, deprived areas in large cities, where there is an insufficient supply of doctors, in particular in primary care, to meet population needs. And often the population that needs more than other places in the country. In such situations, patients' care is negatively impacted due to reduced accessibility and availability of healthcare services. Additionally, doctors, as being the first line of care delivery, are significantly impacted by shortages and bear the brunt of excessive and unsafe workloads driven by unsafe staffing levels. We have seen in the case of some countries, such as France, the recruitment and replacement of doctors in rural areas is a major issue, and that doctors are unable to take leave or retire due to the unavailability of a potential replacement. Personally, I come from Norway. I know France very well as well. I see that we are facing very much the same problems. In France, for example, community level has not a legal responsibility for primary care, but they put a lot of resources into that as well. In Norway, it is mostly the task of the state to finance primary care, but the local level communities have to step up and finance it to assure recruitment. There is no quick fix, and to comprehensively address the geographical imbalance in the health workforce, it is important to prioritize building effective recruitment and retention strategies. Our members have reported on several promising approaches, including recruiting medical students from rural areas as they are more likely to stay after completing training, promoting exposure to rural practice through workplace visits or internships in family medicine's practice in remote areas, both during studies and during specialization, Implementing policies that make it attractive for doctors to work in these areas through a variety of means, including financial incentives, such as better wages or support for opening a practice, collaborative integrated practice models, and improving working conditions and support for doctors with a focus on newly trained doctors taking up practice in rural areas. However, it is important to underline that incentive-based motivational retention strategies work better than involuntary workforce allocation, as the latter leads to burnout and dissatisfaction among healthcare professionals. Some solutions, such as digital health and telemedicine, may have some potential in helping improve access to health services for patients in underserved areas. But we underline that face-to-face consultations remain the gold standard and must always be available to patients. Therefore, telemedicine cannot be used to justify the closure of healthcare facilities in less populated areas. What is key to also underline is that we need better data on the health workforce. Accurate data collection is essential to understanding the real capacity of healthcare professionals available for care delivery. Historically, many countries have relied on headcounts, which do not fully represent the actual workforce capacity. While numbers of doctors are rising in some countries, numbers of full-time equivalents are not keeping pace. With the introduction of many more female doctors, this is a key point. We welcome female doctors. That's very good for healthcare. It's very good for patients. But it makes the figures different. Strengthening data collection and using reporting standards such as full-time equivalents will enable better health workforce forecasting and a more reliable, robust workforce planning. To identify medical deserts, it's also important to be able to break down data per region. In the CEPEN project, which was funded by the European Commission, however, also for more smaller countries, this is not always established in the data collection. It is an important dimension of effective workforce planning. Better reporting and collection of data on the health workforce can also help in the objective measuring of the effectiveness of recruitment and retention strategies. High rates of doctors leaving the professional signals shortcomings in policy implementation. In rural and urban areas alike, proactively monitoring factors such as working conditions and professional satisfaction are crucial, as turnover can serve as a key measure on the success of retention strategies. To conclude, for too long there has been insufficient political prioritization of the healthcare workforce. Actually, the problem started with the economic crisis in 2008, very much, in many countries. We reject the notion that health workforce is a purely national competence. There is key EU legislation, in particular the Professional Qualification Directive and the Working Time Directive, to be enforced. At the same time, the magnitude and cross-border aspects, such as doctors' mobility, data collections, and the international recruitment from the outside of the EU necessitates cooperation. We also cannot ignore that the health workforce is in many countries not only one of the largest employment sectors, but also a precondition for economic and societal sustainability and stability. In the context of the EU's objectives on preparedness and competitiveness, this cannot be achieved without a stable health system with safe staffing levels. Addressing this crisis requires a coordinating effort across policy areas, and that is why CPME is calling for an EU health workforce strategy to ensure that this issue is given the attention it deserves at the European level. The warning signs are clear. Europe's health workforce is stretched thinner every year, I'd like to say every day, and is heading towards a breaking point that will impact patients and professionals alike. European countries share these problems, and we need to cooperate on shared solutions. Our population deserves it. Thank you very much for your attention.
Thank you very much, Dr. Bakke. And this is the moment, dear attendants of conference, when I believe we have many food for thought and need also a couple of coffees for body, which means that we are taking a short break, 20 minutes for coffee break, and afterwards we are coming back with a couple more informative presentations and of course reflection and discussion of Ministers of Health of Europe. Thank you very much. Coffee break, 20 minutes. Dāmas un kungi, 20 minūtes.
Ladies and gentlemen, 20-minute coffee break, and after that some more informative presentations. Dear participants, we come back after a short coffee break, and we are here not only present, but also we are broadcasting our conference online, both in Facebook. There is no live translation option. It's just the floor as it sounds, but on the Health Ministry webpage, there are the options of languages. And answering the questions that have come from those on remotely, yes, the record will be available on the Health Ministry website, and the main information of the conference and presentations as well. Yes, by the way, lost and found, under the coffee table, we found this nice purse. We don't open it, because if there will be money, we don't want... yes, we do have an owner. Great. What was lost is found now, almost like in a TV show, you know? 10% fee should be reimbursed. Yes, well, congratulations. Great, that one task is tackled, and we got an easier view, and we move on towards a discussion that will start after 3 more presentations, where the ministers can reflect on the ideas that we will hear in the next 3 presentations. And this chapter of our conference are the user experience, or those who already work in a daily work in a regrowth of the personnel, and they feel the human resource needs firsthand. Dr. Alvaro Serrano, head of the European Junior Doctors Association.
Always stressful. Applause one more time.
So, good morning, and first of all, thank you very much to the Ministry of Health and the Minister of Health of Latvia for inviting us. We believe that it speaks volume of this forum, and specifically your ministry, to get so many members of the civil society involved, and in particular junior doctors, which is not so common. And I believe that one of the messages I will be sending today, it has to do with the fact that it's really important, in order to understand how to retain junior doctors, to do particularly this very thing, which is to listen to the professionals, to listen to junior doctors, because normally they will have part of the answers, not all of the answers. I understand that I have a difficult task, which is speaking after the coffee break. So I have this responsibility, this huge responsibility. And as I was mentioning, this is going to be the first message, and probably is going to be the one of the 2 important messages that I would just like to convey today. Then I will present many things, also policy documents that we have that might be very useful for all the policymakers and the people in the room. But the first message would be this one. It's important to ask professionals what they need in order to fix part of these problems. I'm not sure if I have, oh yeah, here, something to pass the presentation. If some of you do not know, I'm Álvaro Cerame, President of the European Junior Doctors. We are an organization which represents over 300,000 doctors all over Europe. We are mostly EU-based, and we represent 26 national different countries. And, in my case, 7 years ago, I embarked upon the journey of becoming a specialist in Spain, in Madrid. 2 years later, it was 2020, you understand that many things happened in relation to the pandemic, and I believe that the world and the healthcare systems changed radically. So COVID shaped or reshaped our work and our societies, and I think this experience instilled in us a heightened awareness of the fragility of our systems and the need for agile and compassionate response mechanisms. One of the things that we did back in 2022 is because we were constantly asked about the situation of junior doctors all over Europe. So it was a question which was repeated. There is a huge health workforce crisis, which was like the call to action that I believe it's worth mentioning by WHO, Thomas Zapata's team, Hans Kluge. They did the time to act. They warned about the ticking time bomb. Then they did the Bucharest Declaration and the Framework for Action. In this context, I believe that there was a heightened awareness of understanding how junior doctors were. So we undertook this task, which is highlighted in this report. I will not get into the specifics of this report because it's a qualitative survey about the situation of the health workforce, junior doctors in particular, in 2023. But I invite you to read it because I think it's a very good reading that could complement what is going to be then the actual presentation, which is how to retain and recruit junior doctors from our perspective. Because in order to answer to the next question, I believe this narrative approach to understand how we are doing, it's vital for a big comprehension of things. So I just leave it here in case you don't know it, and I encourage all the policymakers and the people who are interested to have a reading of it. And just to focus on one particular aspect, I believe that before me, Dr. Ole Johan Bakke from CPME was pointing out to this never-ending loop that can happen. And I believe we need to make like a stop here for a second, because in this paradoxical situation that we are in, that despite having the biggest number of doctors in the history of Europe, we are facing a situation of workforce shortages, and we cannot meet all the demand. In this context, this is the loop that I'm referring to. There is this problem that we have problems from retention that stem from medical workforce plan challenges and the things that have already been explained and will be explained later. And this deteriorates substantially junior doctors' experiences. And what happens is that it deteriorates satisfaction, it promotes burnout, and it increases mental health condition as well as the intention to leave the profession. This creates, in turn, much workforce shortages. So we need to do things to get out of this loop and to be moving forward to a different loop. And that's what we'll be covering in a few seconds. What we did in this report, just as a brief mention, is that we saw that the 8 big trends that we picked up were the shared disappointment and job dissatisfaction all over Europe in junior doctors, regardless of country, regardless of healthcare system in 2023. That had to do with workload strains due heightened healthcare demand. That also had to do with a generational shift in the way we see work and the values of the new generations. We must remember that every generation's values towards work are different. This is not a good thing or a bad thing. We can see it from different perspectives. But I believe, or we believe as an organization, that the societies also need to accommodate and understand the different generational perspectives as in the way of the different generational perspective that will come after us. In this case, or in this context, there was what we call the redefinition of the professional calling. This concept of vocation that is very pronounced or uttered in the context of healthcare profession, like as a higher calling that draws us to become doctors, nurses, and other care professionals. But we believe that there has been a redefinition of this calling that encompasses a more humane approach to being a professional, not a heroic figure or a semi-heroic figure, but a human being with needs, with families that need to accommodate this work and life balance. In this context as well, the 5th item we picked up had to do with the rising resignation from clinical roles, and this is something which has not been studied that good. I think it's difficult to study it, but I think with some of the organization and the ministries present could take a look into this phenomenon to understand a little bit better why people are leaving the profession altogether, not necessarily going to other countries. Migration flows are better studied. But if people resign and then do something else in the country, sometimes it's difficult to pick up and there would be like a big portion of workers that could potentially come back and rejoin the workforce. Then the shift in specialty and career choices, as was mentioned earlier, and as usual, we're still struggling with gender inequalities and cross-border mobility experiences, especially in the context of free mobility such as Europe. So now going to the important part, building up from this other report, we created the second report, From Mandate to Motivation. And actually one of the persons that spearheaded this effort was our member from Latvia, Anna Klesmite, and I think she deserves some congratulations for spearheading this effort of creating this report. If you need to consult it, it's online or you can scan it. But basically, what we try to do with this report, it's the second message of this presentation. So if the first one was that we should ask junior doctors what they need in order to come into the profession and to stay into the profession or go to underserved places, the second message would be that's the title, From Mandate to Motivation, that we believe that motivational approaches to retention work better than forced measures in relation to retention. Or as the behavioral economics put it, carrots work better than sticks. So this is the overarching message. And then what we saw, because we normally meet several times a year, and what we're picking up is that in many different countries, they were struggling with these problems in many different ways. So you know that medical deserts are not the same, even in the same country, but also not in the different countries. So we were looking at, there were many different solutions being put into place, but we were worried that at some point in time, there were these kind of solutions that related to what we call involuntary workforce allocation. So we were picking up these different things and we needed an umbrella term to define it. So basically we created this involuntary workforce allocation trying to encapsulate a set of mandatory locational workforce retention initiatives. That is to say, situations in which a doctor or a student is compelled to be employed in a designated location, but under the threat of penalties or loss in remuneration or other situations. Why we wanted to do this? Because what we were seeing, and from the perspective of junior doctors, and it's something that has also happened outside of Europe, and the example of some Latin American countries, such as Chile, I think it's very, it speaks loud, is that while at the short term, it might temporarily alleviate these shortages, in the medium and long term, it may inadvertently worsen these shortages by promoting distress, burnout, and job dissatisfaction. And in contrast, what we advocate for is that priority should be given to this long-term planning, investment, medical training, and especially creating positive incentives. Then one might ask, what are the practices that you think are good? So I would just say, please read the report. You have many different items. I was worried to put some of them here because sometimes it could feel as a shopping list. Okay, so UK has done this, Latvia has done this other thing, Lithuania, and so forth, and so on. So there are instances that from the perspective of junior doctors in those countries, it worked. But that doesn't necessarily mean that it's something that you can just translate it into your own context. And that's why the first message is important. So we believe that in the context of creating these solutions, it's important to implement this dialogue with stakeholders, especially junior doctors, senior doctors, nurses, care workers, and so forth, to understand their needs, because it's going to be different in different places. So if you want, you can use this as a policy tool. You can get ideas that might be interesting and might be nice. But what is important is to get back to your own junior doctors and say, hey, how does it sound? Is this being implemented anywhere in the country? Is this applicable to our cultural context? And so on and so forth. So we were seeing that there are best practices in higher education. I think Dr. Backe mentioned some of them before, like encouraging people from these underserved areas to go into the medical studies, for instance. This is one of the best practices that we highlighted there. Then also about helping people from less privileged backgrounds to get into the higher education and create support systems for them. In relation to the postgraduate training, there were many, many things. I would like just to highlight 2 or 3 of them. One that has to do with contract stability, higher salaries, and is not, because sometimes we focus on just one measure. So normally a set of measures works better than just an isolated measure. And a thing which we've seen that works really good is when the educational needs in the context of postgraduate training and becoming a specialist are not subordinated, they are always partially subordinated to service delivery, because that's the overarching aim of healthcare systems. But sometimes service delivery just is the most important thing, and then the training requirements are not met, or we don't care if they are met. That is something that we don't normally say out loud because it's controversial, but that would be what is happening. So in those cases, there's also this problem of people not learning, not attaining the competencies that they should do it, and in a context in which they're suffering from burnout and so forth. So places in which postgraduate training is protected, and also even in rural contexts, there are experiences in Norway, in UK, and in Sweden about doing rural placements in underserved areas in which they really struggle, or they really take care that the trainees meet their learning outcomes, have respected time allocation to learn, and so on and so forth. So people actually want to go there. So these experiences is not that sending a person or creating rural placements is a bad thing or a good thing. It's what you do during those placements. So you will see that in some cases, creating this during PGT, this allocation to rural places could be both a good thing or a bad thing. It always depends on what you do during it. And as well, during the early career specialists, so creating better contracts, creating flexibility in order to accommodate time for family and caregiving responsibilities, because as we were saying before, there has been a change in the gender demographics in the medical profession, but not only that, it's about how we care within our societies. So since social structures of care have changed, now every doctor have more caregiving responsibilities than they do in the past, which we believe it's a fair thing, because there was very pronounced gender inequalities in that sense. So the work, when you work and you have to take care of not only children, but also people that need care, who can be your elders, or people with disabilities, so that needs to be accommodated within the work, because if that flexibility is not allowed, then you're going to create very bad things. In relation to substandard practices, you will also see substandard practices, but I believe that the most important thing has to do with trying not to create forced allocation measures. And I think it's something that has happened in the case of Latvia, which is one of the examples highlighted here, in which after finishing your postgraduate training, you have this contract in which you need to work in the same place, and then you are liable to a penalty if you don't work for a certain amount of years. It's not only Latvia, but it's also something which happened in Croatia and other European countries. And we've seen that the perspective of junior doctors to this measure is this short-term gain for a long-term pain. So we would encourage to rethink these strategies, because there are many things that can be done, and probably this could also help in these situations. In relation to, this is in postgraduate training, also the not subordination of healthcare needs there needs to be a balance between attaining competencies and seeing patients. And when this balance is unbalanced to any of the both sides, things go wrong or sideways. So I would recommend to take a look at these practices, but always having in mind these two messages. The first is always consult with the junior doctors and the professionals in your countries to see if it fits the situation, what are their problems, and also trying to make it national strategies. It's not top-down or bottom-up. I think we need comprehensive strategies that work both ways. The last two messages I would like to send is that, obviously, and this is something that I believe it's, everybody said it, we need to prioritize long-term workforce planning and retention strategies. And I think this shift that it was done in the framework for action from recruitment to retention, focusing on retention right now, I believe it's a very important change. Incentives over forced allocation strategies. As I mentioned, carrots work better than sticks. Invest in training programs, improve opportunities for career progression, and create comprehensive positive incentive systems for professionals to work in medically underserved areas. And the last three things that I believe sometimes we miss them, but I believe it could be very helpful, is that initiatives should be monitored with regular effectiveness assessments. And if possible, evaluations should be published, because that would help many policymakers, different countries, to know what works, what doesn't work. And I believe there is a little gap here. I understand that also in the context of the ministries of health and the regional authorities and the healthcare systems, you are also as understaffed as the frontline healthcare workers, and sometimes it's difficult to keep up with these things. But I believe that making a little effort here would be very much of help. And in relation to the transparency and clear communication among stakeholders, including obviously junior doctors, I believe that having the possibility to predict what's going to happen and not feeling that you are like drifting in the sea and you don't know if the current is going to take you somewhere else or a storm. It's something that sometimes happens for junior doctors. You don't know where your next placement is going to be. You don't know if you're going to be able to, I don't know, buy an apartment or be able to have kids because you don't know where you're going to be or if you're... So I think that this transparent communication and creating predictable scenarios is something that would help both the healthcare workers and the healthcare system in their aim, which is treating patients and the population as best as possible. So I think, and this is just to finish, that the pandemic has reinforced a critical lesson, which is that resilient healthcare systems are not built overnight. They require sustained investment in infrastructure, personnel, and care and recognition to the professionals who work on those systems. And I think this mandate becomes even more powerful in the context of this world in which our security is threatened. So I believe that the message that was given in the first part of the morning by the Ministry of Health that has to do that compelling us to view the healthcare system as a strategic sector essential to our security and our societies, it's one of the most important things that we can do, and it's one of the important things that we need to remind in order to continue tackling the health workforce crisis. So thank you very much.
Thank you very much to Dr. Cerami, and of course, organization he represents. Thank you indeed. A lot of insights and ideas from user perspective, and in this moment I'm switching back to Latvian. Tātad lietotāja pieredze.
So this user experience is created by the institutions, the organizations that take care to then also take care for the change of the personnel and now experience from the universities.
Augsti godātais ministrs.
Honorable Minister, participants of the conference, colleagues, dear ladies and gentlemen, I am honored to tell you today about the challenges, problems in healthcare for preparation of healthcare specialists. You might probably know that there are 2 universities in Latvia that prepare both nurses with bachelor's degree and other healthcare specialists, and also doctors, physicians. And now Rīgas University experience I will share today. And you probably see this chart not for the first time, and in your countries of residence you have probably analyzed this. This does show that the healthcare professionals are getting older. Unfortunately, Latvia is no exception here. We see the particular group not only older than 65, but 50 to 60-year-old specialists in Latvia. Their share is rather big, and we know that practically in all categories of healthcare specialists, we need the healthcare specialists, new healthcare specialists. Talking about the statistics and what is the statistics, we found out how much there are physicians and nurses and vacancies. I will show you now, but I think that there could be absolutely correct or correct statistics. So if we compare our statistics, for example, with Charité in Berlin or Johns Hopkins in Baltimore in the United States of America, then the proportion itself for such inpatient hospital, so what is there a proportion of one physician and patients? So how, or the proportion of one physician and nurse that take care for the patients. So these proportions may vary, and for us it is difficult then to compare data with Denmark, Germany or other countries, because we have our own data, we have our own accepted proportion, and talking about the fact that whether really there are 329 vacancies for nurses and 427 unfilled vacancies. Actually, there was 3,500 vacancies unfilled for nurses, and also for doctors it was thousands. But then The real life, dear colleagues, already forces us to think how we can replace these positions, how we add to these positions, and how we can facilitate the replacement. Now, in the secondary school, are the students interested in going to study medicine? There's a research in Latvia where they surveyed more than 1,000 young people living in Latvia, teenagers, grades 11 to 12, and you know that 33%, especially women, girls, would like to be in the medicine field or healthcare. And that's not bad, because only 7% would like to become engineers, and in energy field also other are the numbers. So healthcare, 33%, means that we could be rather optimistic. Now, talking about to what universities they would like to go, that is both Rīgas Strādniecības University and Riga Technical University. But basically people express desire to stay in Latvia and work in healthcare and be in healthcare in general. Rīgas Strādniecības University currently is third largest university in Latvia after the consolidation with Latvia Sports and Pedagogy Academy, we have become bigger and we have almost 12,000 students. We have 5 faculties, more than 60 study programs. But of course, if we're talking about the amount of reflectance, and there's going to be a crisis, and however, Rīgas Strādniecības University is actually happy because 12 to 13% is actually the growth of enrollment rates for Rīgas Strādniecības University. And we wonder, why is that? 8 to 1 is the competition to 1 placement, also in dentistry, in physiotherapy, etc. This competition is really high, and they are ready for it. And if we talk about the number of the students, we see, for example, 11,755. 28% of our students are foreign students, students from abroad. And we are also leaders in attraction of students from abroad in Latvia, in the Baltic states, and also in the Nordic states. Because every year we attract a lot of students from Scandinavia, from Germany, from Israel, Canada, and elsewhere. Talking about that, what is approximately a distribution of graduates? Rīgas Strādniecības University every year issues such proportions. So light blue is English speaking, Latvian speaking is dark blue. 200 in medicine and in dentistry, 33 is what we can prepare. Then also other other programs. It's not little, but if there was such an order, so to say, for us to produce more, we would be ready. How do we know that? Because we have a capacity to teach so many foreign students who then, for the most part, also leave for their countries of origin and work there. So the attraction, why people are dreaming, aspiring to become healthcare specialists. There are reforms that also give the results, but at the same time, for more than 10 years, that is the result of our work. And for example, there's a new healthcare specialist academy. We fill in 100 vacancies in 40 seconds. Whenever we announce another 100 of vacancies, now within a minute we have 200 vacancies filled. The same is with all these new schools of nurses, physicians, and also for participation in the fair School 2025. For example, the School 2025, the latest fair, is where we saw so many candidates that came to us. They would like to become our students. We do cooperate with schools in all Latvia, not only in Riga. We're talking about nurse, physician, doctor professions, and we are advertising, and basically we believe that this is also our responsibility to invite people to go into healthcare field. There are various preparation courses, trainings that are available, very much attended. As I said, there's also this competition, this tender for one position, and if not in presence, then at least remotely we try to provide counseling for students to choose healthcare. Of course, we are also helped by various digital activities, AI platforms, where we show the privileges even more so. What would happen if the colleagues would go to study primary healthcare or in the hospitals? And of course, we do think a lot about the fact for our studies to be competitive and extremely modern. You know for yourselves how much it has changed after COVID. Previously, all the patients went to university hospitals, spent there 3 or 4 days or maybe even 7 days. Currently, hospital admits only seriously ill people. So outpatient treatment is ever more important, observation departments, etc. And upon teaching new doctors, we need to take it into consideration because the healthcare field very much changes. Also the AI products, digital health, and also various problems with human resources, policy solutions, community health issues, data protection questions, security of patients is all what is included now in the Medicine 3.0, where we are heading over to more such logical studies, less learning by heart, maybe making more conclusions on our own and making some logical decisions. Military medicine is also a course for the second year already with us. Now we started with the Faculty of Medicine, but now we have also other professions being involved, and for the security of state, this is very important course. And of course, the program needs to be very, very modern. Now we are also developing the simulation technology application, both in dentistry and medicine and other healthcare fields. And it's not just dolls, it's not just mannequins, but these are simulations, quality control, etc. That is communication with a patient, and that is why we are working in this regard. Of course, for this program, we need to invest. Talking, then further where these simulations even are occurring, taking place everywhere, in hospital, in various other settings, in our campuses, in our central building, Dzirciema 16, where there is all the dentistry, pre-clinics, and Aniņmuižas Boulevards 26, that are one of the best premises now in Nordic countries. It's a center for simulations. Of course, we are talking about cooperation with large university hospitals and clinics, and I would like to express gratitude so much to all the 3 big university hospitals, regional hospitals, where our students go for internships, practices, where they can be shown and we can show them various difficult patients and we can discuss with them. We have new study research center for pharmacy. This is also at the disposal, this is available to our colleagues, where there is labs, various labs with substance research, and also students, doctorate degree students' involvement in research is going on. And whether foreign student amount increases, yes, gradually, at 7% rate. And the question is, why do we teach the foreign students? We are, of course, doing that to develop our university, to fill the budget deficit that state cannot pay to us. And then also the students obtain an opportunity to learn from the professors, from guest professors, and also we have more than 110 such professors in medicine, in dentistry, in pharmacy. That is an international know-how, science, digitalization, AI platforms, and of course also mobility and in all other aspects. Talking about the geography, I've already said, and if it was to be expressed in one sentence, then now Riga Strategic University is Scandinavian and Germany student university. Now, contribution to the economy. On one hand, we are preparing high-class specialists. We are delighted to see that also with educating the foreign students, and we are working on the export for this education. Per year, that is 140 million euros, our contribution to the economy of Latvia. And from 25 to 27, it was 500 million. The money which is really, really very necessary for budget in Latvia. As you might have noticed then, for the 9th year already, that is the leader of reputation, that is an anonymous survey that is being done in all the universities in Latvia. We are trying to also maintain this high bar. Today I'm telling thank you very much to all the partners of cooperation, to the Ministry of Healthcare, to the Minister for support in also educating our students. Thank you. Thank you, Professor Rector Aigars Petersons. This is the view from university, and our third block of reports now can be split into several experience stories, and for conference organizers there's also this is like devoted to user experience, something that gives us the expertise from everyday life. We're going to now see three stories of experience in the life of healthcare specialists, from the nurse, from a new doctor, and also from an experienced doctor. And now these experience stories is always a challenge, because one thing is talking about certain systemic things, fiscal consolidation, implementation, etc. That is actually easy to be talked about in a way, because these are already now well-known words, first of all terms, but in our everyday life we actually encounter certain emotional words, or something that we can only express in some private circles. And that is why I would like to invite you to applaud and to encourage the form of such experience stories now publicly. This is going to be the first time. And if it's the first time, then, well, this is also in front of all the ministers of health in Europe. So, Gundega Pilsnica and her story. Dear ministers, hello. All the people who are present here today, dear audience, I'm really honored. That is going to be indeed the first time I present in front of such honorable audience. This is going to be my experience, my story. I am a nurse for 39 years. Next year, I will be 40-year. I will mark the 40 year of experience, and also the hospital is going to be 40 years old. Now some technical considerations. I come from the city where the wind is born. That is a windy city, I guess you all know. That is the third largest city in Latvia. That is Liepāja. And in Liepāja, I mean, at least I work in the hospital, which then is 40, turns 40 next year. That is Liepāja Regional Hospital. My story began in the old, and I mean the former, different country, we can say now this is the nurse school, and after the nurse school I had 3 diplomas. One was medical nurse, nurse for taking care for children, and reanimation nurse, and this was the challenge. For the last half a year we were offered to work as anesthesia reanimation nurse because they had to open new hospital where in the department respective they needed specialists. And this is what was actually my first work. But after that I graduated Rīgā University twice. I obtained more diplomas, and in the country of Soviet Union, nurse education was professional education. It didn't have bachelor's degree. There was no higher education like that. But in order to work in this field, I had to have higher education. And here you can see how many other times I studied. And additionally to that, I will show you later that these are my places of work. The first, as I said, this was the Department of Anesthetics and Intensive Care. Then I went to Children's Hospital. I was a children's nurse. And then in 1995, I became a senior nurse. I accepted this challenge, but then I understood that I do not have any knowledge in human resource management, because that is indeed a challenge of taking over a hospital of 60 beds, and in the healthcare field at least. And then in 2000, when Liepāja University opened up the program of business management, I went there to study business management. There I studied for 3 years, and of course this knowledge and contacts I gained, I am applying today too. That is very good for my organizing work. Now, I'm still working as the high nurse, and then I am also studying for palliative care for children. And in 2011, we opened up in our department the palliative care cabinet where I work today. This is also sees various challenges, this field today. We are working towards having the mobile brigade for palliative care in Kurzeme region. Here you can see how this work is conducted. This is being the head of the department organizing this work, and another is palliative care. Actually, this is all very related. That's not a university hospital, it is a regional hospital. Here I am applying the knowledge which I gained in business management studies. I'm going and establishing contacts, and for all the work in the department would go smoothly. Also, for example, we have certain events and we decorate the department. So this is basically a constant work, cooperation with schools, various companies, organizations. And sometimes the person thinks that everything or something significant happens in Riga. But actually in regions we also take care for these things and manage. We go to cooperation visits, we go for study visits, maybe something we don't do in our everyday life. And then as the head nurse of the department also, I understood this right away, that each person working in your department, I believe this person to be in my department, meaning part of my department. I'm there from day one, and these are values. Starting from a janitor, ending with the doctor. If, for example, the janitor does not come to work, then it's also a huge problem. And if we're not going to, then pay also for the work of the cleaner. And in order to even be working there in operation block, they are studying for 2 years, or they have to practice for 2 years. But we take a cleaner from wherever and are making, meaning asking them to clean the hospital. But no, what is the result we can expect? It is actually there are necessary additional studies and skills. And of course, the new colleagues and various schools, and now we had this Day of Shadows. Usually when they go to the Day of Shadows, everybody wants to be the shadow of a physician. But the administration, well, so to say, administration of the hospital, we sometimes agree that, for example, if it's a grade 6 or grade 7, these children would actually go to nurses, and we will be telling them about the profession of nurses. Because if they, for example, come certain amount of people, 6 people, let's say, and we ask them, who do you want to be? They say cosmetologist or a model. And I'm like, what do you do here? And they say, okay, I want to get acquainted with the profession. Next to us, standing next to that, standing a 12th grader, and they want to become physician, pediatrician. And we say, okay, then you go to the doctor to see the doctor's work. But if you are younger, then let's go to see what nurses do, what physicians in general do. Then we will, in such a way, introduce you. How can I go back? And so, the second work of mine, as I said, it's Children Palliative Care Cabinet. And actually, they say that that's my hobby. You know, in 2019 we launched, now it's for 14 years already. Quite a hobby, isn't it? And then it's an interesting topic. We have study room for patients, for patient parents. We have opened up this study room and center, and now we are educating colleagues, new colleagues. And these are the dolls we have. So whenever there's procurement in the hospital, it's actually an interesting detail is that they say, for example, try it on the patients. And I'm saying, maybe you bring your child for us to maybe put in tracheostoma or something. How do you expect us to experiment with the health of children? But these dummies, then we either suitable or not, but we are studying on them. And definitely, it is true. We all need to study. We all need to learn. We are doing whatever is offered to us by our country, but we in Liepāja have this a lot of wind sometimes, and we use international studies, go somewhere abroad. We have international magazine club where we have an opportunity to contact colleagues from around the world who can connect, and we have established these contacts as our friends already during our visits and trips, and sometimes we can discuss maybe that there is some kind of a serious case we don't know how to solve. That is when we communicate. So we have also nurse magazine club, and there we can exchange with experience. As you can see, this is another example. If the country does not provide for it, then we enter the plane and fly somewhere for exchange of experience ourselves for such events. Here we are in Erevan, and also we learned about palliative care a lot for children and for adults both. This is great events to establish contacts and make friends. And now we are also contacting with all the people seen here. There are people from Tartu, from Munich Nurse School, who work specifically with palliative care nurses. We can ask them for advice at any given moment, and this is how we work. And here in Liepāja, this is now already third, I think. Well, I put here a couple of last years. I don't think I could show you all 40 years in just one slide, but this is school. In summer, we're working towards the next one. Now this year, the event we would organize, there are adults and children, and based on the experience of our foreign colleagues, we clearly understand that palliative care cannot be studied by sitting at the desk. This is by cooperation, talking, and interactions. I'm somewhat stressed, but to maintain our team, the palliative care team, well, I'm not the head of the team of palliative care. There we have a colossal Cīru Legāls, the doctor, the physician, which is the head of all that. But as the department, well, how to stay in all of this? As I said, each person is valuable, and we do not have high turnaround of personnel in our department. But what to do if we are getting older? How to attract new professionals? And if there are no vacancies currently, then we'll see. We'll see how it will work out. And we have together some boat trips, hikes in Drift Arena. We went there to, maybe there was after some serious case, to unwind. And so, as a company also, Liepāja Regional Hospital offers us various possibilities, sports games, quizzes. And what helps me not to burn out is really this, that I am not forbidden to do what I really like, that I can express myself. And here I really would like to express gratitude to the management of the hospital that for all those years they have allowed us to work and have never been as an obstacle to all of that and never asked, oh, what are you doing? No, and for also in palliative care, we are grateful to have supervisions, sort out ourselves, talk about various situations. Well, that is life, basically, and this is how 40 years go by, and very quickly. My daughter is 18 this year, and she's looking at studying in Rīgā University, the Faculty of Medicine, and she's sitting there saying, oh, 40 years? No way, it's boring. And I say, what is boring? It's not boring. If you understand what is the purpose of your work, and you will love what you're doing, because medicine, the same, as Latvia or Riga or something else, is never ready. There's always something to be done. Everywhere. I'm Gundaga Bliznica, nurse Gundaga Bliznica. Thank you, thank you. And really, it's like an added value to see this overall image. But we are heading over to the next story of experience, Edgars Maļcevs. Dear audience, ladies and gentlemen, ministers, association, thank you for invitation, and thank you for the invitation to tell my story here, to present it. And this is the story of experience. Based on my experience, everything that is offered by local governments, Ministry of Healthcare, and also university. I've gone through that. Unfortunately, my story is not yet 40 years, but, well, I'll be there soon. I am within these blue diagram fields. I will always be in these charts as 32-year-old, meaning currently, but my story started in Valka, the town that is not in Riga, but I know that Latvia does not end with Berģi, meaning the vicinity of Riga, and I practically have been in all the territory of Latvia. I graduated the Faculty of Medicine and was resident of surgery, and now in Liepāja Regional Hospital I work as a surgeon. That is our beautiful Latvia. This is where my story begins. Valka is there, where it is now shown on the map, and Valka is a town where Latvia actually begins. And there begins my story with my family, of my first education. And as I will later also address this, it is the basis for me standing here in front of you and being a doctor. Then I go to Valmiera, where new young man decides to be a firefighter, but actually then changing their mind and deciding to be a surgeon, a doctor, and goes to Valmiera State Gymnasium, where I study in the Faculty of Natural Sciences. Then, successfully, by passing all the exams, I get to Riga. I go to the Faculty of Medicine, Rīgas Strādniecības University, and fill in the budget place.
Yeah.
Yeah, that's a significant point of my story. So it's a sort of a success story, starting from the 9th grade in the school and during the medical faculty, going through the hospitals and getting different experience stories from my group study members. I'm aware that I don't want to stay in Riga. I want to go back to my homeland. My hometown, there is no more hospital. Okay, I think, okay, I'll go back to Valmiera, but they don't need surgeons anymore. Then I move further, and I'm in Liepāja. Alvaro asked me during coffee break, what is longest travel in Latvia? That's my experience. It's 5 hours non-stop from Liepāja to Valka. Therefore, based on this story, I want to draw some accents on what I see as crucial points. As someone who has reached the profession of doctor, I'm not related to in a medical family. We don't have a dynasty. As a firefighter, I go to the school, and he gets amazing biology teacher on the 9th grade. I get such a nudge that I decided to become a surgeon. And here we can talk a lot about medical profession and many other things. But still, it's very important to connect with our educational system. With the school, with the early years in the school and the program developers for those early years in the school, so that even from primary school we can redirect our youth to the necessary professions. It's amazing that the professor mentioned the interest education, different type of clubs, after school activities, where we can really taste the medicine, because I have done everything, both helping to wash the homeless people up to the top-notch technologies of medicine. Therefore, I can speak about my calling. What's the first experience? Somebody wants to drive a new car. Where should we get the money to buy it? Where can we get our material supplies? Those could be first institutions where we can get our experience in hospitals, in the local clinics, where the patient doesn't meet the requirements of the film studio, but they can have smells and dirt and a lot of things. And then we go back to the quality of studies, what we bring to our universities, what's our luggage of knowledge in medical faculty. First 2 years, they are extremely challenging, I must say. And then further to making your own life plans, what we want to achieve in our life, what do we see next to us, what are our work conditions, and of course, the material benefits. And everybody needs to pay the rent and the invoices. And what will be our daily routine after we finish? And my calling is when you wake up in the morning, finally one can go to work. So I'm very happy to wake up 6 o'clock in the morning to go back to work. Okay, I don't speak. I'm not speaking about night shifts, of course, but where we finish our residence internship, when we do think what we shall we do further, and there we need someone in the institutions like regional hospitals, municipalities, who make for us those pathways to go to the most needed locations. And we face deficiency of the personnel also in Liepāja as a regional center. We see it, the real background of all the opinions heard in the first part of our conference today, and we need to do everything possible so that people who live in Latvia and work in Riga, we do need to help the regional population to meet their doctors there where they live. And my story of my family, we live and work in the place where we are ready to build our future and wait and celebrate those 40 years and more in medicine. So it's the caring area of the municipality to provide the good working conditions for those young families. So summarizing this brain in the middle, I see it in a way that I want to work in the center of region in a multi-profile hospital, but at the same time I want to live in a beautiful city with a development-oriented mindset of municipality, so I can spend time also outside of hospital well. I would look for an internship for the budget funds, and I see that those regional contracts provide me with some good feeling that and knowledge that after internship I'll be able to develop my professional career in the same hospital. And then I will have the place to live for me and for my family. How do I navigate through all of this? In the Rīgā University, we have a free vacancies platform. My road to Liepāja wasn't just a free flow. It was through this vacancies platform I get acquainted with administration employees who were very much development-oriented, and I was ready to go 6 o'clock in the morning for my shifts. And I'm very motivated employee, and I hope my employer is also satisfied with me. That's how I have developed myself. I have reached my target that gives me a chance to work in the consultation polyclinic in a hospital. At the same time, the regional hospital of Liepāja supported me with a transport compensation, helped me with finding the place to live, and our children got a preschool, and they just moved from Riga to knowing where exactly, in which preschool my kids will be. And of course, Liepāja has a lot of beautiful features. For instance, the seaside beach, also the material goods, that I get a stipendium from municipality, and thanks to our healthcare ministry, I have received also the financial compensation for moving professionals that really helped to resolve questions with setting up my new place of living and new place of working. Thank you so much. Thank you very much to Dr. Maltevs. I feel Liepāja lobby on this stage. Liepāja city lobby is active. And now we move on with our experience stories. Edita Vītola, a family doctor from Vidriži. Hello, honorable participants, honorable ministers, colleagues. After such a creative representative from Liepāja, I won't present you with such a creative approach, but I have a very responsible task to represent very experienced doctors of Latvia and this conference. As a family doctor, I can express my private experience and opinion from the family doctor's standpoint. Right now in Latvia are working 2,101 doctors at 33.72%. In 2022, from the informative report of Health Ministry, there were 30% in the retirement age. In 2 years, there is growth by 3.72%. As to oppose my younger colleague, already 7 years I am retired, but I continue working in my family doctor practice in Limbaži parish, Vidriži. That's my first and only working place since 1978, when I started my working career after finishing a medical university. You colleagues know that time it was a Rīgā Medical Institute. My family doctor's practice is according to the optimal model. I'm taking care about 1,600 patients. There is a number of children below 18 and up to 12 children who are less than 1 year old. And 333 are the retired people, seniors 65 plus. I have a team of the nurse, administrative personnel, and I have yet another supporting employee. There are several reasons why the family doctors continue to work in their practice after their retirement age. But I believe many of them have a similar situation like me. First of them is love. They are loving their profession. Knowledge, skills, and experience that is earned in a long years of work. Very significant is mental and physical health. As a great support is a teamwork in practice where colleagues I redistribute the duties between the colleagues, and we are working with mutual respect and support. I believe that family doctors should give as much as duties away as their assistants can handle. Our generation of doctors and family doctors particularly had to work in a very complicated period when the state changed from socialism to capitalism. When from therapists we became family doctors, from the employees we became employers, entrepreneurs. Besides the colleagues who are still employees, most of us had to create their practices and set them up according to the new regulations with a very limited financing. Hence, many of us purchased the premises, took the loans, and were not able to pay themselves salaries and taxes. And that has brought us to smaller pension payments. Therefore, financial aspect is also significant. Family doctors' practice transition is very significant in the generation transition. The state health service payments to when there is a transition of private practice, particularly in the rural areas, are 5,400 euros 5,400 euros, and that's 3 average salaries per month in Latvia. I believe this payment is way too low in comparison with a family doctor's investment when he creates a family doctor's practice, and the intellectual property acquired during years of taking care of the patient's health. But when the family doctor decides to practice without establishing practice, he still has to pay the compensations to his employees as an average monthly payment when the team member worked for less than 5 years, 2 average monthly payments when there are 5 to 10 years of experience of the team member, 3-month payment when there are 10 to 20 years, and 4 months when the team member worked more than 20 years in a practice. In my situation, when we work together more than 20 years, those would be more than 15,000 euros. Those are really big expenses and even impossible for too many of us. Therefore, I invite our politicians' health ministry, together with the Association of the Family Doctors, to resolve this issue about quitting of the family doctors' practice payments, so that our very experienced doctors wouldn't get as much involved in a relationship with the state, just like in their family, in their marriage vows, where it's till the death will us part. Thank you so much, Dr. Viktola.
Moment when we are bringing together all the information that was before from perspective of user until, of course, the calculations of economists within the Europe. And this is the moment also when the conference is built very smart. Questions and answers and reflections are directly from the politicians. And that's why I'm asking here on the stage, and of course to bring the good energy in the field with the applause, the panel discutants and ministers at the same time. Hosams Abu Meri, the Health Minister of Latvia, please welcome, take your seat. Cyprus Minister of Health, Michael Damianos, please with applause. I feel like in Eurovision somehow. 12 points goes to Lithuania. Lithuanian Health Minister, please, Vice Minister with applause, Jelena Chelutkiene. That's a good position. Vice Minister is like a minister. Of course, it's a good, much better, much better. Montenegro Health Minister, Vojislav Šimun with applause. Slovenia Health Minister, State Secretary, Denis Kordež, with applause, please. And of course, World Health Organization as a panoramic view giver and analyst, Europe branch, Dr. Thomas Zapata, please, with applause. And let's play this game in the way that I will raise the first question. And the first question is also a slot and chance for you to give out your prepared message, as it should be. And the first slot is some 4 or 5 minutes, and afterwards we are going in a very alive discussion. And my questions will be only provocative today to keep the adrenaline high. And the first question is, can you describe from political perspective that healthcare, human resources is really priority, not just designed for the sake of this conference, wonderful of ours, but that's really in the agenda. It's really with the backing and your personal perspective also here will be your personal mission in the place. And we will start with we can take real host of this event, Hosams Abu Meri. Please, the floor is yours. It works. It works.
Really?
No. Okay, let's take mine. Okay.
Yeah, thank you very much. Es domāju, kolēģi.
I believe, dear colleagues, my dear colleagues, that today it's not just a discussion where we all note some crucial points and then everybody is leaving and forgetting what we discussed. This is a question that was, is, and will be a priority of all times, because it's a crisis where we need to really look for a solution altogether. And today we heard several speakers, both from university and the OECD, also the experience stories, what can we improve, what do we have from the positive side, and what do we need to change and improve. I believe the road that demonstrated from Valka to Liepāja across all the country, that the cooperation among the municipality, state, and educational quality, both in the primary school to the high school and university, are really crucial. They all together should work in a coordination, and there cannot be a good municipality and then there is bad municipality and bad vacancy. Therefore, human resource is moving affected by this difference. So this doctor or nurse decides to stay not in his native city or not to stay in the capital because Riga, but he decides to move 500 kilometers away to build his life. Therefore, we need our stakeholders to be involved together on the same table all the time, not just as a single measure, and to try to follow and monitor this implementation who's made decisions of the budget fund availability. How can we look forward strategically for 10 years and more? And you saw in the presentation of OECD where they mentioned that we, Latvia, are on the second place by the number of students finishing the university. So we increased both the budget places available in university, and also we worked for 4 or 5 years more budget for the internships. And there is a positive tendency that all the students who finished, almost all students who finished medical faculty got a possibility to continue in internship paid by the budget. If we look back 10 years ago, half of them were looking for an internship to get some grants from municipality or pay themselves, or they just left the country. We lost a lot of colleagues within 10 years when there was a worst crisis in our history back in 2008 and 2009. Therefore, people couldn't pay themselves for their internship. Also, the salaries were challenging, low. So a lot of financing was directed for the financing, but we still do need the financing. And the head of our professional association will talk more about it. We cannot create the long-term human resource strategy without increasing of the remuneration. Last year, our prime minister mentioned that in 2024, the healthcare was a priority in our budget, and we sort of get 275 million. But honestly, it was 140 were only the debts. So we had 120 million, and 75 of them were only for the remuneration. But we do understand that in a medical institution, this those 70 million went a little bit to those professionals like nurses and nurses' assistants and doctors' assistants and lab workers. They got like a 10% increase, and that's not a lot. And we see the difference between the doctor's remuneration and nurses' remuneration. What is very important, not just increase the budget of places in this for studies, but also give an adequate offer of working positions. And our colleagues from Liepāja and from Vidrieži, they mentioned that work environment is highly important. So when we work as a team and as a young doctors association, we are working with them tightly about improvement of the work environment. Beautiful premises, human doctors' primal rights, the human rights, where that they have a nice, nice place to live and rest. Also, the respect from the more experienced colleagues. Also, in Latvia, we had to increase the use of Latvian language. It was a challenge. That's why I'm challenging myself with that today, how to increase the usage of Latvian language when there are Latvian citizens or not citizens who don't know Latvian language. So, and young doctors, they're thinking to leave the country just because there are too many patients who cannot speak Latvian. But I will go on speaking, and I better stop now because my colleagues have come across all the Europe. Everybody has their own experience, but my priority while I'm on this position, and I believe also the health ministry as a creator of policy has to develop the strategy and work in these directions.
Yep. Thank you very much. And it's a good position when there's more than one health minister on the stage.
Otherwise, I'm going to speak all the time.
Health Minister Damianos from Cyprus, please.
Yes. So, you know, the workforce is definitely extremely important within health. I mean, what we really have, we have buildings, medicine, and employees. Employees are doctors, are nurses, and all other health employees. So in Cyprus, we have the general health system from 2019 that has definitely increased needs. I would say potentially more than the needs across Europe, because from one day to another, we have free health. So that creates further needs. So buildings, you pay, you build buildings. Medicine, you buy medicine. With workers, it cannot happen within a day. You need to find a way of attracting people to do these jobs. So obviously, we need to pay them well, which we are. We need to train them well, which we are. But we need to find a way to keep them within the profession. The best way to keep them within the profession is to have the correct, let's say, the right conditions for them to work in their own workplace. And from our experience, it's not just the buildings, it's not the pay, it's their ability to have time off. And because we have shortages in especially nurses, the problem lies there. They're not happy with their work because they are overworked. Mm. So what we're doing, we have long-term solutions and short-term solutions, especially for nurses that are the biggest problem within the country. We have run a campaign in the summer, which we are going to repeat, so that the number of students entering our universities to study nursing has doubled this year. So we have paid 40% of our communication budget as a ministry, which shows that it is important for us, so that we attract new students. Obviously, that's going to solve the problem in 4 years' time when they're out of university. Is it going to be enough? It could potentially be enough. The other thing we're doing is to, because one of the main issues that nurses to come up with is that they're actually undertaking tasks that are not their job to do, that the job of a carer. So we're trying to train people to become carers. We are, at this point in time, trying to push, let's say, training programs so that you can become a carer within 6 months, let's say, rather than a year or two. So you do it fast track, you spend more time doing it so that we employ people, and there is money to employ. That's what I'm saying. The money is there, the people are not there. So to train carers so that we employ within hospitals and we take the burden of things that the nurses shouldn't be doing out of them to someone else whose position and job is to do that. So this is for the short term. Another thing that we're trying to do on the short term, because we are in Cyprus we speak Greek. in order to be able to be employed as a doctor or as a nurse, you need to speak the language because you need to be able to communicate with the patient. And it's very difficult to attract people from abroad because who speaks Greek? Us, Greece. Greece has the same issues as the rest of Europe. So we have negotiated a bit with the trade unions of the nursing profession so that we come up and agree, let's say, a plan where we're able to employ third country nationals, teach them the language to an extent, have them within the hospitals to be undertaking mainly tasks that they don't need to be in direct contact with the patient at all times, or be in groups that are in contact, so that for a bit of time we solve the short-term problem. Because otherwise, what you're actually getting is a lot of people within the nursing profession want to leave hospitals and go to primary care or to be doing office tasks, which is impossible to do. So within the nursing profession, that's it. With respect to doctors, since the general health system, we actually do pay them well. Trainings there, we have recently sent doctors to train with respect to professions or specializations that we cannot do it in Cyprus, like hepatology. We've sent to Germany recently. It's impossible to be able to train people in a small country in something so specific. So we do try and train them, make them happy with respect to what they're trying to do, but definitely within specific special interest or specializations with respect to doctors in small countries. It is very difficult to have people and it's very difficult to attract, so we need to train. It will take a bit of time, but we think that it's the only way forward. Because I've seen the graph this morning. Well, Cyprus is on at the very top with respect to training its own doctors, and I have to say that it is a problem being able to train within the country. So we need to use countries, EU countries, to do it for us until we're able to do it ourselves. But I think as most small countries, it's going to be rather tough to be able to train all your staff within the country. Unique situations need to be trained abroad if we are to care for them within the country. So I think I'm probably running out of time as well, so I'll leave it to someone else.
Thank you. Thank you very much. Yes, I believe this dilemma about attracting students and not ignoring this problem, but taking as a part of the policy, taking into account European-wide issue, it's really on the table. Vice Minister, the floor is yours.
Thank you very much. It is my great pleasure to be here. And first of all, I would like to congratulate this conference and especially the host, the Minister Hossam Sabameri, for organization of such fruitful and such relevant conference. And it is a big pleasure to be here. And the best greetings from our Minister of Health, Maria Jakubauskienė. We work just quite a short time. We work just for 3 months, so we are new government in Lithuania. And during this time, we shaped our priorities, and we issued what are our 6 priorities. And the first one is enforcement of human resources in the healthcare. And we put some concrete measures, projects in our plan of our political cycles. And first of all, this is attraction of specialists from abroad, and doctors and nurses, our Lithuanians to come back, and also to get people from other countries to attract nurses, most probably, but maybe not only. And also to try to stimulate those who are inactive now, who are medical specialists but don't work as specialists for now. And we allocate funds for that. And also for another project, what we have in Lithuania, and maybe it is also a little bit similar in Latvia, that we have a huge concentration of doctors in our big cities. First of all, Vilnius, Kaunas, and also Klaipėda, also quite rich in doctors, we should say, but all other cities, peripheries, municipalities are suffering from the deficit and lack of doctors. So therefore, and nurses are quite equally distributed, we have to say, between regions and the capitals. So what we also decided to put quite a big sum of money to push and attract specialists to our municipalities, to our regions, and we work with municipalities together, and they have to find these young people and to agree with them that they will come there for some good positions, for some good remuneration, for stimulation of their stipends and all these enforcement of their environment. So another thing what we plan to do it is also to improve the attractiveness of career of nurses. We plan a lot of new programs for advanced nursing care for them, and we would like to have them more and more also, and to show that they can reach also interesting and self-sufficient career, not be just doctor's assistant, but to be clinical leaders. And we also try to show and to organize this specific pathway for nurses. Also, we would plan to put a lot of money also for postgraduate education of our specialists, also keeping in mind very long waiting lists to our doctors. So we would like also to get them more education. And also, as already many recent years, we work on the improvement of the salaries of medical specialists. And here we have to say that in Lithuania now doctors, I think, have very good or very good salaries sometimes, but it is not the case about the nurses. So we still need to improve the ratio of salary between physicians and nurses. And lastly, to show how important is the human resources for our ministry, I have to say that we came together with the head of our human resources department, with Diana Smalukaite. I know that many people already knows her here in Latvia and internationally, and Diana works already for 7 years in this field, and therefore for us it is much easier to make a progress.
Thank you very much. And we are naturally passing the microphone further, and Minister Šimun from Montenegro, please, the floor is yours.
Well, thank you very much for this conference.
Can you keep him closer a bit?
Yeah, of course.
Yeah, thank you.
As you know, every Ministry of Health has the health workforce as their priority, but has the country seeing the health workforce as a priority? That is another question. Well, Montenegro has taken some tangible steps regarding health workforce and to demonstrate that they are a priority in our country. In the last 4 years, we have doubled the wages of doctors through two big government reforms. And I must say that we stopped the exodus of our doctors, which was very big during the period of 2014 till the 2020. For our system, the outflux of doctors abroad was 150 doctors plus, which was very big for our small country, because we have around 2,500 doctors total. So with that reform regarding wages, we stopped a bit that exodus. Also, we recently have made an arrangement with nurses to make some kind of a financial incentives of 5 to 10% on wages regarding their workplace responsibilities. Monthly, we pay them that bonus. At the same time, with the trade unions, we are negotiating a new collective agreement that will improve, I hope, better working conditions and job security for them. But I must say that we recognized also one critical area, especially regarding the doctors and other medical workforce in rural areas, and that is housing. So, Ministry of Health with health sector housing cooperatives have made projects to build buildings, especially for our healthcare workers. And we've just finished a building in the south of Montenegro, on the seaside, in beautiful town of Kotor. The next one will be the biggest building for healthcare workforce in capital city of Podgorica. And the next step are 2 buildings on the north in Montenegro, in rural areas, which we hope to attract and to make our health workforce stay there, because we are providing them homes. So that is a big project, and Ministry of Health is a part of that initiative, even with money on yearly level. So I hope that is a good initiative. We also, as a ministry, have 1% of those flats in our ownership, and then we can use those flats for maybe doctors who came to our country as a consultants, to stimulate them, to maybe accommodate them, etc. I must say that I've recently also doubled the monetary means for young doctors who are on specialization on abroad. We, as a small country, we have a medical faculty, but post-study programs of specialization, we do not have many. So we send our young doctors to Serbia, Bosnia, even to other European countries, but mainly Serbia and Bosnia. So I doubled those means for them to have means for living expenses. So that is something we have also done. I must say that beyond financial measures, we are also committed to improving the infrastructure, of course. So now in Montenegro, in the north city of Montenegro, it's a poor city, economically poor, but we have doctors there, and we have a small hospital which is in ruins, I can say, in shambles. We are going till the end of the year to start the building of the new general hospital there. Also, we are planning to build by the end of the year the biggest primary healthcare center in Montenegro, in Podgorica, regarding the primary healthcare workers, because we are also doing some kind of reforms with primary healthcare system. Well, we recognize that they have many administrative burdens, so especially in primary care, and we are doing everything to reduce those through optimization, digitalization, regulatory changes, and that ongoing reform is strengthening also the role of family doctor, giving him a greater decision-making authority and more quality time with patients. And that is something that is very well accepted among our doctors. Well, also with medical faculty in Podgorica, we have a very good connection, and we have made better chance for our students to enroll the faculty by a simple law. Everyone who tracks the entrance exam can be enrolled. We had a fixed amount, quota, of students before, so even those who do the entrance exam and passes them, that is not a guarantee that you will be enrolled to faculty. Now that is not the obstacle. Also, as I mentioned, we send our doctors abroad for specializations. Since I came to the position a year and a half ago, we have tripled the specialization programs in our medical faculty. So now they can enroll anesthesiology, family medicine in our country, radiology, and few others, epidemiology and etc. So we are, that is something that we must do with, as you see, Ministry of Education, local communities, and Ministry of Health. That is all one circle which empower all health workers. I must say also that it is very important for a Ministry of Health to be sincere, to be transparent in public and also with their health workers. That is something we are striving to do, and I think that open communication and culture of collaboration with healthcare professionals is very good. They say that now in Montenegro they feel heard, they feel supported, they feel valued. So those are small steps we are doing from every angle, but to empower their position and working conditions. Thank you.
Thank you. Thank you very much. And we are passing the microphone to State Secretary of Ministry of Health of Slovenia, Mr. Kordesh, please.
Yes, thank you. It's really an honor and a pleasure to be here. Not just because this theme of today's discussion and the whole event is crucial and important, but also it's one of my priorities, was before I even came to Ministry of Health, and it's still one of our greatest priorities in our mandate. So the first thing that we established in our ministry, organizational changes were made. We established a sector for human resources in healthcare. So this was number one. And then I have to start also with the money, of course, because we are still in our wages reform system. We implemented already at the beginning of this year the financial part of our wages reform. So it's already started with January, and it will be continuing for the next 3.5 years. So wages will rise in the next 3.5 years constantly. Of course, we divided in groups, those with the lower income first, and then with the highest income a bit later in the process. And we are still now continuing negotiations with unions on the normative side of the collective agreement, so based more on working conditions and etc. So, but besides just payment rises, we also are implementing a bit more concrete workload and performance-based bonuses and incentives. So, leaving from the money to other measures, we have our national health program by 2030, which of course prioritizes our population health, but still it includes improving working conditions for our healthcare professionals. And we are actively promoting and funding training programs and specializations, and we are also introducing new ones. So we are especially funding specializations for clinical psychologists, and in this year we will achieve a really important historical milestone for Slovenia by introducing specialization for nurses. So we are moving into advanced practitioner nurses, because all of the evidence from the other states are showing that this is a positive practice, not just to relieve or taken the burden on some levels from the doctors to nurses, but nurses on this side will be more motivated to stay. It will mean the career development for them and etc. So I think there's a lot of positive effects on this level. And I have to stress out that in Slovenia, all of the study programs are free of charge for all of the students, and also specialization. So for all of the doctors. All the specializations are free of charge, so are funded through national budget. So no one has to pay for not for the study, not for the specialization. So this is one of the good impacts. I also think so. And then on the other level, we are working on our national legislation measures and changes. We have made some changes to our Medical Professions Act and Healthcare Services Act, and also we are implementing, it's currently now in our parliament, the act on the recognition of professional qualifications in healthcare for foreign workforce, because we all heard that we have to do as much as we can to our own national workforce. Of course, the production is not as big as the needs are. So we have to combine. We have to focus on our own and also import foreign workforce. It's the same system in all of the member states. So this is one of the changes that was really needed in Slovenia to make import process easier and to relieve the administration burden and the period of time that is needed to get your qualifications approved. So we also increased a number of admission slots in our medical faculties, but it's still not enough. So we already signed an agreement last year with one of the universities to establish a third medical university, because the interest for medical study is more than doubled from the available slots. So this is one of our key priorities, and this one faculty will be together with all of the health science programs. So it will be a faculty that will have under the same roof medical doctors, nurses, physiotherapists, etc. So it will be already multidisciplinary process of studying. So and we are really proud of our work that is also based on the experience from the WHO. We are currently preparing our national strategy for healthcare workforce development and management until 2035, and it will be, I'm sure of it, accepted before the end of this year, with short, mid and long-term effects focused, of course, on effective workforce recruitment and retention, creating competitive, attractive employment option and professional development. We are currently present on every possible social media. Also, we involved in our process some of the online promoters of healthcare professions, and we are actively recruiting all over possible. So besides that, we made some systematic changes in the emergency system. We introduced a rendezvous system for emergency doctors, so to relieve the burden from them, that they are acting on the field just when there is a medical indication. So otherwise they stay in hospital, in emergency centers. Okay, they go out on the field just when it's really needed by their own emergency vehicle. Okay, so it's quite a progress, and we are also implementing 15 of satellite smaller emergency centers through the country to take the burden off of the biggest hospital, university medical centers, which have the biggest ERs, because our ERs are really crowded. So we are trying to shift this into regions, okay? And also on the emergency medicine field, we are implementing specialization or advanced practice for EMS personnel to be well equipped by knowledge and competencies to act like they are already in 80% of all interventions are made by our EMS personnel. So we just have to build them up a little steps further. So not to be too long, I think that this is quite of some positive steps in the way of improving our working conditions. So thank you.
Thank you very much. And the floor goes to Zapata, so World Health Organization, with a focus on Europe. How is this really priority? And you're taking time.
Yes, just to stick to the 5 minutes. No, thank you so much, and thank you for the invitation, because I'm the only one not in this club of ministers or state secretaries. So, but just to, my question, I was thinking on, is really health workforce a priority at the regional level? That's what I was trying to reflect. And 2 years ago, you know that we published this report, Health and Care Workforce in Europe, Time to Act. And in that report, with evidence, we really raised that there was a health workforce crisis. And it was raised by Francesca before in terms of shortages, in terms of geographical distribution, in terms of mental health of the health workforce, increased health workers leaving the profession, the aging, that's why we call it a ticking time bomb. And we were surprised because in most of the big newspapers across the region, we had headlines. The Guardian, they took our press release, a ticking time bomb. Why was it? Because all countries across Europe were experiencing a health workforce crisis after the COVID pandemic. It was there before, but it came much more apparent during the COVID pandemic. And when we also look at the strikes or protests, there have been a 24% increase globally in terms of protests and strikes of health workers across the globe. And I think this is putting a lot of pressure on whom? On all of you. Because you are the ones, because I'm sure that if I ask you how many nights you couldn't sleep because of health workforce issues, you will say a lot of them. So I think this is a key issue, a key priority for most of the countries in our region that is putting a lot of pressure in all of you. What we did in WHO, we went for the Bucharest Declaration, we organized a regional meeting with all of you, 50 countries, professional associations, collaborating centers, everyone. What we did? Signing the Bucharest Declaration, which was essentially to try to elevate at the political level health workforce. Because we always heard that health workforce is a key pillar of health system, blah, 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 blah. But has it been really prioritized? And that was what we tried with the Bucharest Declaration. And then we put it at the central political agenda. And we have a window of opportunity with COVID. And from there, working with all of you, 53 countries, we went for the Framework for Action on Health Workforce. And this is very interesting because it was the only resolution that was passed in the regional committee in Astana 1.5 years ago. And we had Russia and Ukraine in the same room, Armenia and Azerbaijan, and the war just started, and the European Union and Russia. And we have hot topics on gender and hot topics on war. And all countries managed to come to an agreement that health workforce, it was such a critical issue, such a priority issue, that they had to come to an agreement to pass the resolution. So for me, I think that was a sign that that was a key priority for all of you to be able to reach an agreement and leave all the discrepancies aside. And then from there, now we are as WHO in a new, era. Hans Kluge, our regional director, you saw him this morning. Now he has been re-elected and he has done a round of consultations, 5 public hearings, bilateral meetings with many of you, and what he keeps hearing is, please, keep health workforce as a priority. Because we are struggling, we are not sleeping at night because of these things. So Hans is going to keep it as a priority, and in the public hearings it's very interesting, because it was not only in the health systems or universal health coverage public hearings that health workforce is coming up. It was coming up also in the emergency public hearing. It was coming up in the NCDs. It was coming up in the aging population. It was coming up in all the different public hearings. So I think health workforce plays a critical role across the board in health in our region. And then from there, it's going to become a key priority for Euro in the next program of work. But I think we don't have to be naive. I think Minister raised it this morning. That window of opportunity is vanishing. We have a totally different geopolitical scenario, and I think we need to be smart on how we place the narrative on health workforce and overall on health to keep it high in the political agenda. And I think it's really smart, the argument that the minister raised this morning in terms of how health and health workforce is critical for health security in our countries. So we can play that narrative so that we can get more attention and resources from ministers of finance and ministers of economy. And with that is at 4:58. Thank you so much.
Wonderful, wonderful timing. Thank you. We have very short answers, one and already final round, so I will combine a bit together because there's a question, stop bragging about what you have done, what's in the future. They are politicians, people, so that's a part of the game. But I'm linking that together with the question which is upvoted the most, which says, thank you for the conference. The question is, what's next? What's the plan? We understand the crisis is here. What's the next step? And I will link together to bring this down to the narrative of the most authentic you of each of you. Conference ends, you're going back to your home countries. What's the first thing but you're really trying to do in the, from your shoes in the healthcare sector personnel issue? And we will start from opposite side. This time, and no, he said already everything. That was already the workload. Very good, thank you. But from political perspective, you're going home as a state secretary. What you're doing tomorrow morning?
Yeah, well, I really have to say, I have to stress out this again. It's, of course, I am at a political position, but still, first of all, I come from the field. I am a healthcare worker from the bottom of my heart. So, like I said, I came to this position, and one of my priorities is definitely a health workforce. So, I'm not making a political speech, and I'm not bragging about, but I have to brag a little bit on all the measures that was made, because, like Thomas already said, we lost quite a few years. And the pandemic had to show us the real human workforce crisis that we are facing right now. So we have to put our money where our mouth is. This is the most important thing, because I think that it will be a bit more of a topic in the next panel discussion, but still, Belgian presidency put in council conclusions, health workforce is one of the priorities, has to be, and this is the main focus of us politicians. We have to put pressure on the Commission to have healthcare and healthcare workforce as a priority. And how safe are you if you don't have people who are working in a good, systematically arranged healthcare centers? If you don't have people, you don't have a system. If you don't have a healthcare system, you are not safe, you're not secured, you're not good at prevention whatsoever. NCDs or war side-wise, whatever you want. So what is my priority? Going back home, focus again on the work that will wait for me, because today I'm here, don't have the time to work. There is my colleague from the head of the sector for human resources, and we are continuing with the unions, with the workers, and with our planned strategies to do everything that we can to convince our own Ministry of Finance why the importance of investment in the health workforce is so important, and to continue to push this agenda forward. So not to be too long, that's my agenda. Thank you.
Thank you. Going back home, speaking with the Ministry of Finance. That's, I believe, kind of routine all around Europe. Thank you. Thank you. Thank you very much. Yes, please.
Well, regarding the planning of human resources, we have just started the human resources development plan for the next 20 years in Montenegro. That is something that would be my top priority, and I hope that the first draft of that plan would be by the end of May finished. And then starts the real job. Where do we need to enhance on primary level, secondary level, tertiary level? What specialization? How to make the specializations more approachable? I spoken to Minister yesterday. I am also finishing the law regarding the healthcare in Montenegro, which is the founding law for the Ministry of Health. And I want to make young doctors which work in primary healthcare centers to give them specializations without waiting. That is something I want to do as a first step, as a reform, to enhance them to work in primary healthcare systems as family doctors, as pediatricians, as radiologists, as gynecologists, but in primary healthcare centers. In our general hospitals on secondary, tertiary level, they need to wait more, they need to do the internship more longer. But with that change of law, which is proposed, I think that I would be in much better situation regarding the primary healthcare system. Human resources development plan, I've seen it, seen the study about that, and the real gap, the real gap is in the primary healthcare system in Montenegro. Our tertiary level is even overburdened with doctors. Secondary is enough, but primary healthcare level is understaffed, and it has very old doctors there, which will be in pensions in 5-10 years. So that was the meaning why we developed that plan. The plan is also with some professionals from Slovenia, because 20 years ago, Professor Schwab was someone who has done the reform of the primary healthcare center in Montenegro, healthcare system. Now we are working with him and also Professor Tit. I hope that we will get a good plan and sustainable. With that plan, I go to the Ministry of Finance, of course. But that is the reality. He says to me, well, I gave you 20 million more budget this year. Why are you spending so much money on medicines? But he does not understand. Half of the budget for medicines I spent for oncology therapy, for expensive therapy, for innovative therapy, because I want my population to live quality life. It is not spent on antibiotics. Yeah, we have a big usage of antibiotics, but what do antibiotics do? They do a patch. But for those rare diseases, for those diseases regarding oncology therapy, when we can give a chance for our people to live longer, to live quality life, we need to do innovation therapy. So I think that health must be prioritized in every country, even through that economic view, because when you do not have people who are healthy, who produce, then what is going to be the funding of the economy? Yeah, that is close circle.
Thank you. Thank you very much. I believe I think in archetypes. I already see the picture from the Scorsese's movie Gangs of New York, from one part comes ministers of health, from other part comes ministers of finances, and fight. But it's really which means we are all on the same boat, and argumentation can be really exchanged, because fighting for the narratives is the battle across Europe. Lithuania, please, the floor is yours.
Here today, I'm peacefully just filtering the topics for postgraduate education, which we organize now, the project that we put a lot of courses, training courses for our nurses and doctors. So it is a very peaceful part, but also fight is on my agenda too. And what we are doing now in Lithuania, we take steps to get back our doctors from the private sector to the public sector. So we are trying to avoid a collapse, actually, of the public sector. And that's why on Monday, I straightforward will go to the television and to radio to participate in the public discussion, because it is a very tough question, and we keep it very important. So these are our agenda.
Thank you. Thank you very much. Yes, please, Minister.
Okay. So money is important. I would say that we need to keep putting money into the workforce. So, I mean, the discussion with ministers of finance needs to be there in the long term, not necessarily for now, but money is important. So that's one thing. Second is to try and reorganize ourselves a bit more with respect to how we use the workforce, because there will always be room for improvement in putting the right people at the right position. I mentioned earlier about carers, so use more people who can do different tasks, doing those tasks, so, because if you do have a shortage, you need to see how you deal with the shortage. Keep spending money in trying to attract youngsters into health, not just nursing, but anything. Persuade people that, you know, it is the future. Persuade 17 or 18 years old or people that they need to, that they can work into health, and it kind of guarantees them a job for the future and for the long term. And I think communication campaigns do work well. It has proved very good for us, and we will keep doing that. And I think that's one of the main things I will push. And the fourth one is continue the discussion with the trade unions with respect to attracting people from third countries. If we cannot, within Europe, have all the people we need, and we try and train people, we need to deal with, let's say, that there's more shortage that we're going to have by attracting people who can do it. I mean, if you're able to pay to have the best people, fine. Let's try and use the resources we can within the Union, or within Europe generally, and try and attract others from outside the Union. It's going to be something in the short term, but it is definitely something that we need to keep the discussion on. That's it.
Thank you. And
yeah,
yes.
Really,
circle of life.
So 30 minutes. I will speak for 30 minutes. So I'm a gastroenterologist, and I look at your faces and I feel that you want to eat. So just 1 minute. Tomorrow, Saturday, Sunday, Monday, I will keep fighting for additional allocated finance. This is very important for us. Second, we have a lot of plans, but we need money to implement. So you can write plan, you can write strategies, but if you don't have enough finance, so we're just speaking to speak today. Of course, in Latvia, we have a little bit different situation regarding the workforce from the third countries, because we have a specific situation, so we cannot think about that. But we are very thankful for the Ukrainian doctors. We have 250 medical personnel. That's why we had this image today, 7%, something like that, because of Ukrainian and other citizenship doctors from other countries. So tomorrow we'll keep working on the finance. We'll keep raising the awareness that health sector is a part of national security and European security, and we have to work all together. And at the end of this day, I will have some comment and conclusion. So, thank you. Good appetite.
Thank you. At this, bringing back microphone to me, thank you very much. At this particular moment, we had many, many questions, and those questions will be answered and taken into discussion. In the next panel discussion we have after the lunch break, just using possibility. Please, can you look at me, ministers? This picture is narrative. Very good. And definitely thank you very much for being here and building up the common narrative for the common Europe and each country in this thing. Thank you very much. Let's give a round of applause. And we are back in 1 hour. Dāmas un kungi, mēs esam atpakaļ pēc mēs ieejam atkal režīmā, kad esam gatavi darbam, un darba ritms saglabājas iepriekšējais, informatīvi.
So the informative message, new facts, new ideas to expand, and again a lunch break, and then concluding discussion where the health ministry representatives on a high level of detail will talk about necessary solutions. So we jointly can resolve this present crisis. The languages, we still have 2 of them, Latvian and English, and so we can keep our rhythm good. I'm now moving to English language.
Continuing, and our first speaker in this session is already famous with his energy and information. So please welcome with applause Dr. Thomas Zapata from World Health Organization. And now I understand that that was just a teaser, and now comes the real information. Yeah.
Now I have bad news, because I already said all I wanted to say in the presentation. So, no, thank you so much. I have 15 minutes, so thank you so much. I think it's a little bit tricky, because after lunch is always tricky, so I need you to wake up and see if I manage to wake you up. And as Martin was saying, I'm going to try to focus on what can we do. So moving forward, and moving from a health workforce crisis to health workforce solution, to health workforce success. This is a report I was referring to before, and something I would like to say, because I was talking to Francesca from OECD before. I think this is a good practice, because you know that we are coming together, OECD, WHO Europe, and Eurostat, in passing a common joint questionnaire that we call, so that we are not overburdening countries, so that we get the same data, and then we share the countries, and then we share the data. So that means that the data that OECD has, Eurostat has, and WHO has is basically, in the core indicators, the same data, okay? Which I think is important, because we are not overburdening with 3 different surveys to the same country. And then in this report we did these country profiles on health workforce. So I really encourage you, if you want to go and see Latvia, how Latvia compares with other countries in the region. And the report, as I said, you see, I was not lying. There was a lot of headlines in the newspapers, and this is the one I mentioned in The Guardian, a ticking time bomb. And I also said before, these headlines came out because this is a big issue in most of the European countries. So it's not unique for Latvia. And this is the slide I was referring, 24% increase globally in the number of strikes of health workers protest. So that's another signal that that we had a health workforce crisis. I'm not gonna get into the data because Francesca already did a great job, but all I want to show you is that we have more doctors than ever in the history. And Europe is the region with the highest number and density of doctors worldwide. So we have more than ever. And you can see that in most of the countries has increased. Actually, there has been a 20% increase in the last 10 years in the density, the number of doctors per 10,000 population, and an 8% increase for nurses. Even if Latvia, as you know, there has been a reduction and is well below the regional average, as Francesca mentioned before. But overall, we have more health workers than ever. So the question that I'm raising to all of you is, why are we having then a health workforce crisis? Why most of the countries are facing shortages and a crisis if we have more health workers than ever, more doctors and nurses and other professionals than ever? And that's what I'm trying to reply very quickly with this. This is the supply. And I think there are 5 main factors contributing to a reduction in the supply of health workers. The first one is aging. It was mentioned this morning. On average, 30% of the doctors are over 55 years of age. But in 13 countries, more than 40% of the doctors are over 55 years of age. This is a huge crisis because all of a sudden, there is a tsunami of retirements. And that's really difficult to absorb by the Ministry of Health. It's really stretching the health system. So that's why it's so important. The second one is the health workers' deaths. And this is not big numbers, but it has a profound impact in the mental health of the health workers. Many of you, if you are health workers, you know someone who passed away during the COVID pandemic or has long COVID and is on absenteeism, is not working, on sick leave. So has a profound impact and is contributing to this sense of dissatisfaction. So I think that's why it's so important. The third one is migration, and I think this resonates to you. We were discussing yesterday in the dinner. In Latvia in 2008-9, the financial crisis, there was a lot of migration to other countries in the region. And then the government took it seriously, increased the salary, different policies, and you managed to bring them back. But in some countries, that's a major factor to reduce the availability of health workers. The fourth factor, it was discussed this morning, is the increase of part-time jobs. It's the full-time equivalent that we were talking about. So before, health workers, doctors, or nurses were working 50, 60 hours a week. And all of a sudden, the new generation say, no, I'm sorry. I want to have a work-life balance. I want to work, but my hours, according to the European Directive of Working Hours, we'll mention later. So what means that if we want to address the same demand, we need more health workers. So I think that's another element. And the last one is increased resignations because of poor mental health, because high stress, high burnout. Health workers are leaving the profession. So at the end of the day, this is the supply, and this is really pushing down the availability of health workers. And what is happening with the demand? We were talking this morning about this. Aging of the population. And look at this one. This is really powerful from my point of view. This is over 65 years of age, the green line. Look at the increase. For the first time last year in 2024, the number of people over 65 surpassed the number of young people under 15 and keeps growing the gap. And the same for over 80 years of age. From 2010 to 2050, the population over 65 will double. And the population over 80 years of age will triple, 3 times more. And this is really important because the population over 65, 1 in 10 requires care, long-term care services. But the population over 80 is 1 out of 3 that requires, 3 out of 10, sorry, that requires care. So this has huge implications on the health system, on the workload, on the demand, on how we link up with the long-term care services and all that. So I think this is really critical that we take it into account. And then we have other elements like mental health should be here, I missed that one, increase of chronic diseases, multimorbidity, that is also increasing the demand for services, the backlogs during the COVID pandemic, increased waiting lists, all these things. And this one I think is also very important, which is increased patients' expectations. I think we live in a consumerism world, and more increasingly patients want everything here and now. And sometimes some of those things are not that important that should be covered by the system, or are not that important that should be covered within 24 hours. So I think we also need to reflect on that increased demand. So at the end of the day, what is happening is that the demand is growing at a faster pace than the increased supply. And it's bigger than ever. But still, we are not being able to match the increased demand. That's the message, and that's why we are having a health workforce crisis in most of the European countries. So what can we do? So this is the Bucharest Declaration that I mentioned before. Many of you were there, and actually you can see Álvaro here. So he was there, I can say he was there. But everyone, it was beautiful. Everyone signed the declaration. 300 people, one by one. Cristina was there. Maureen was there, many of you were there, signed the declaration. There was a personal commitment and a country commitment to really elevate health workforce at the central political agenda. And then from there, we developed the framework for action, and this is the resolution we passed that we were referring to, and this is the framework. Normally, when we talk about health workforce, we always start with production, with training. We change that narrative. We put health workers at the center. And the most important immediate action is to retain the health workers in the system. We normally talk about recruit and retain. Here we swap. We said the first action is to keep the health workers we have in the system. We have invested 10, 15, 20 years in training and experience. If one of them leaves, it's a catastrophe. So we need to improve the working conditions so that health workers have the right environment and the right working conditions to thrive, to shine. The main motivation factor of health workers is not money. It's being able to serve your patients. It's being able to develop your profession. That's what we need to ensure as a health system, that they are able to thrive. Because if health workers thrive, the health system will thrive and patient outcomes will improve. So that's the whole message, improving working conditions. And this means that we need to look at the workload, the cycle that Álvaro was talking about. Very high workload, burnout, dissatisfaction, and that leads to more workload, and that leads, it's a vicious cycle. We need to break the cycle by improving the working conditions. Then we need to improve the work-life balance. That's a reality. We cannot live like in the past. The junior doctors did a beautiful study in Spain. You know what is the average number of hours, working hours of doctors in Spain, average? 55 hours a week. 55 hours a week. The European directive of working hours is 48 maximum. So we need to take into account these things because the new generations, they really appreciate, they're not going to take this. As Francesca was saying, they will go for ICT, they will go for other things, more flexibility, better salary. They will not take it. So we need to change the way what we offer, more flexibility to the health workers if we want to keep them. And then here, we were putting in this British Medical Journal paper the importance of retention as the core, okay? And then now we are working with the European Commission and 19 countries, and many of you are there, on improving retention of nurses and recruitment of nurses. Latvia is one of the countries. Here you go. First thing we are going to do, a baseline assessment of working conditions in these 19 countries. We want to understand what the working conditions are, so that when we are working with countries in improving policy interventions, we will be able to show if there has been an improvement on those working conditions. I think that's something really important. And we are working jointly with different stakeholders, unions, professional associations, because that's the way that we align together and we work together. I think we cannot go in isolation. We have to come together. And then another aspect to retain health workers is mental health. So also joining with the European Commission, we just finished, yesterday we closed the survey, doctors, a mental health survey and well-being of doctors and nurses in the European Union countries, 27 countries, plus Norway and Iceland. How many responses do you think we got? Not many. How many? 5,000? More? Limit of optimism here, come on. 101,000 responses. Health workers are worried about this. This is important. For the first time, we have a large survey in the European Union that will give us the picture of what is the mental health situation of doctors and nurses. We will expand to other workers in the future. But not only the photo. What is important of this survey is that will give us some of the root causes of this good or poor mental health that will come out, so that we can work with countries in improving those policies to improve the mental health, and we will be able, on a regular basis, to pass the survey and compare the trend and the evolution, okay? And here, I'm showing this slide again, because this is also very important. Francesca already referred to this. We have fewer and fewer students out there. And we are competing with other sectors to attract them to the health professions. And as Francesca said from PISA, I have the slides here in a different way, ICT, this is OECD graph from PISA. They are much interested on ICT, as Francesca was saying, and less to the health sector. If you look at nursing, from 2.8% to 2.3%, decreasing interest in nursing profession. So how we attract the new generations, this is critical. And I think we need to think about this, how we make it attractive. New generations, they want a sense of purpose, a sense of impact. They are also worried about green components, how we can sell that agenda to them as well. How we can bring innovation, new technologies, because they like those type of things as well. How we can make it attractive that they're going to learn through their whole career. That's something important. The flexibility, the work-life balance, the geographical mobility. We heard the nurse this morning, 40 years in the same position. The new generations, they don't want that. They want to move from one to another. And we need to change the contractual agreements and everything so that that's possible, okay? And then migration is another element. We did 6 country case studies on migration, successful. I'm not going to get into detail. The code of practice and the bilateral agreements, but I'm not going to get into detail. And this is a critical pillar, the second pillar. I'm not getting into training, I'm moving into optimizing performance. Because for me, this is the critical pillar. The retention is in the short term. The optimizing performance is the mid and long term, because we need to address this issue of changing demand. So here, I'm coming back to this, because for me, the problem in Europe is not a problem in the supply. 37% increase in the production of doctors in the last 10 years. 26% increase in the production of nurses in the last 10 years. It's not an issue of supply. It's an issue of demand. It's an issue of how we rethink health services in a way that we maximize the performance of the health workers we have in the system so that they are able to cope with the demand. And in that sense, I think we need to start making tough decisions in a sense. First, in public health interventions, how we manage to reduce the burden of disease so that lower cases come into the system. That's the first one, I think, here. The second is how we de-medicalize. We need to reduce the medicalization, because in many cases we are medicalizing a lot of things that should be normal, that the person and a family deals with it by themselves. And that should keep at this level, self-care. They don't need to access the system. So we need to keep as many people as here as possible. And then, Mike, yes. And then we need, thank you. And then we need, and then we need to look at the unnecessary demand. In many cases, in Denmark, you don't go to the emergency department straight. You call. You make a phone call, they ask questions, and if it's not relevant, they tell you, stay at home, take this pill, paracetamol, whatever, and that's it. Or they will tell you, go to your GP. Or they will tell you, go to, you know? So I think we need to start channeling the demand in a way that we are reducing the burden in the system so that we can treat the things that are important. So I think, and then here we need to channel to primary care, to hospital, to long-term care. And in primary care, I think it's really important that it's not anymore just the family doctor or the nurse. There are many professionals that can take the burden and that they can share as multidisciplinary teams. Anyway, I'm going quickly. Thinking about the health system. And here it comes in the optimization. The way we think is in a linear way. We have our experience, some more or some less, but we think in a linear way. And I think we are now in exponential change. I think we are here. We are already there. We are already starting here. We don't know how the future is going to look like on health systems. That means that our organizations have to be open-minded, to be flexible to respond to the new changes. Change is for sure. And we need to be, as health workers and managers, be open to change. Because that's the only way we will be able to cope with the changing needs. And here is when the skill mix comes. And here is really relevant, the skill mix. It was discussed before. What can nurses do? I'm sure in Latvia, nurses can really play a much more advanced role on what they are doing, not just being assistants of doctors. They can really do much more as they do in other countries. Pharmacists, they can do more as well. So multidisciplinary teams. I think we need to rethink the skill mix, the team composition. I'm moving quickly. Then second element that I think is really important is reduce wastage. This is the rule, the healthcare paradox, the 60-30-10, which more or less is that 60% of care, of clinical care, is according to clinical guidance, to evidence. 30% is low-value care, is not really bringing any added value, and 10% is actually damaging the patient. So we need to rethink services in a way that we maximize this and we reduce wastage. So we need, in other words, we need to stop doing to be able to do the important things. Because if health workers have a very high workload with a lot of things that are not really bringing added value, that means that that one who really needs access to care will not get the care he or she needs. So I think we need to prioritize. That's really important. And here, now, the hospital reform, we are working with Karolinska, with Charité, with 11. This is the NHS. These are the three major objectives now, guidance for the reform. From hospitals to community and primary care. From treatment to prevention. From analogical to digital. I think we need to rethink the health system. That's the message that I want. And health management, leadership, I think is critical. Not only at the top level, but at the mid-level. How we train our mid-level people in this change so that they are able to implement all these things. And here, always putting the people at the center. As we saw, needs are changing. So we need to reorganize, rethink the organization of services, including the social sector, the integration between the health sector and the social sector. And then we need to realign the health workforce. So I think always putting the people and the communities at the center. And then the third element of optimizing performance then is the digital health and the artificial intelligence and the new technologies. But let's be careful. Let's make sure that the objectives, that they are really responding to the needs of the system. We were talking during lunch, how many new apps, new technologies are coming up that are not assessed, are not evaluated, that are not bringing any added value, and are a waste of resources. So I think we should take new digital technologies as medicines. When a new medicine comes, it's properly evaluated about the effectiveness, about the cost, so I think we should do exactly the same. And we should engage patients and health workers in the development. Because at the end of the day, they are going to be the ones using those technologies. So they have to be easier for all of them. And then this is not just a substitution. I think it's a complement for health workers. Let's look at it in a positive way, not in a negative way. Because health workers and the human face, the high touch versus the high tech, will also be needed there. So I think that's really important. And then we need to train health workers. And just very quickly, build supply. You see, I'm not going to spend much time. The numbers, the competencies, the digital health, all those things we still are required. Then the planning, the data, really important. Latvia is now putting an e-registry, workforce registry in place because we need good data to take good decisions. 2 weeks ago, we organized a regional meeting on WHO on data and information systems. There were 37 countries in the meeting, and I think there was so good practices from different countries, Estonia, Spain, different countries showing their systems. And then I like this one, is we need to plan long, 10, 15, 20 years time, as you are doing in Latvia. But that means that we need to monitor frequently, like sailing, no? You want to go there, but then you have to keep changing all the time. You need to monitor frequently. And then you need to start acting now. So it's plan long, act short, monitor frequently. So I think it's very important why we have such an aging doctors' workforce in the region. Because there was not a proper planning before that end up, that all of a sudden we realized we have a huge problem. I'm moving quickly. This is the small countries. We have a group, we are meeting once a year, a technical working group. Many of you are in that group, and it's such a rich group, honestly, because the cross-sharing experiences that we have on policies that are working, that are implemented in all these countries with less than 2 million population is really, really rich. And then once a year, there is a ministerial meeting. You will see many of the ministers today. It was in Cyprus. Then we had another one in Luxembourg and another one in Montenegro. And always health workforce has been a priority. Developing health workforce strategies. And Latvia, Malta, you have been pioneers in putting these strategies together, as you have put the, I know this is not the official version, but I couldn't find another one. And then, this is the technical working group in Malta. Maureen is there. We had all the heads of human resources for health units of all the small countries, and it was so beautiful to share good practices on the different pillars of the framework on what is going on. And it's so, you know, there are so many things. I'm not going to get into detail because the ministers already mentioned a lot, but pillar by pillar, there are so many things already moving. Finding solutions for the health workforce crisis. And this is the tool we have for forecasting of the health workforce that we are working with Slovenia now. Denise, the State Secretary, was mentioning it before. With Malta, we work with it also with Malta. So we are working. And now, on the 20th, this is a little bit of advertisement. On the 28th and the 30th of April, we are organizing a regional symposium on health workforce modeling and optimizing performance. All these things we've been discussing. We're going to be 3 days. We received 160 abstracts, and I think it's going to be rich in terms of conversations. And the last one is not just about more money, but a smart investment. So I think we need to think very well where we invest the money for health workforce. And just to finalize, this is the government in Spain, the first day of the government. The Prime Minister is in the center. Over the years, you see different Prime Ministers. My question to all of you is, where do you think is the Minister of Health in the photo? Come on. Where is the Minister of Health? Sorry? In the back. You're not giving much value to the ministers, huh? We have many of them. More answers. Where is the Minister of Health? Eh? He's working. He's not here. He's in the pandemic. That's a good one. I never got an answer like that. That's a good one. You are right. At the back and in the corner. And where do you think is the Minister of Finance? In the front and next to the Prime Minister. So I think let's not be naive. We need to work out our narrative to make a case for health and for health workforce. We are not the most powerful ministry, and we need to really work hard to make a case. And for that, I think we need good evidence on policies that are working to really influence and get there. And then the last one, this is a Lancet paper we published with the framework, which is moving for health workforce crisis to health workforce success. Let's stop talking about the negative things and let's keep moving, implementing together as you are doing in a positive way, because by working together, we can really improve the working conditions so that the health workers can thrive. And second, we can optimize the performance so that we can prepare for the future, the health workforce. Thank you so much.
Thank you very much indeed, and I can definitely say that I'm gonna rewatch this again and again, like a binge watching on Netflix when you do with your favorite TV series. But thank you very much for the energy, but extremely great framing narratives. That's very, very important. And the picture about minister, where is the minister? That was very, very interesting. Thank you. Well, we continue, and now I'm switching back to Latvian. Kā jau mēs konferences sākumā arī.
As we highlighted at the beginning of the conference, we're not only looking across or over the borders of the European Union, we're also exchanging the information within the field or maybe with related fields. I mean, who is actually related to such field late in the afternoon? We're not sure, but I am very glad to now welcome Kaspars Gorkš from Confederation of the Employers of Latvia and their view, their perspective on the healthcare employees workforce. Well, you can have a mic and be more dynamic walking around. You can also be standing here next to a fixed. Yeah, I will be static more so.
Talking about crisis, it's something that we Latvians don't possess, but very impressive. Thank you. Yeah, if you don't mind, I continue in Latvian.
When I was addressed, when I was asked to present about the crisis, first of all, it was a surprise that I even have such an offer. On the other hand, I could assess from a side how it works. Okay, there has to be a clicker also, a remote.
I can't give everyone. Yeah.
That gave an opportunity and our Confederation experts to have a look into the healthcare workforce situation, because the employees in general, or workforce, is a very closely linked thing, because the human resources matter in Latvia is very topical. It is also elsewhere, and healthcare as such is also the problem for other areas, because on that depends how healthy the workforce is going to be in other fields and how available and qualitative will the services be. So in our opinion, that is very important to look at the data, because when we are looking about human capital, we're talking about the workforce. Of course, we understand there are so many things that do impact the workforce availability. And that is how we usually also love, rambling about, talking about, just finding some kind of generalized solutions. But in our view, these problems need to be addressed in more detail, identifying particularly the problem and looking at how we can solve it. Now, nurse and physician numbers, we're not in the quadrant we'd like to be in this indicator, or we're not there where we would like to head. I mean, if we count the data and look at the last years, this movement from this quadrant had not really occurred to any of the sides we would like it to be. And that is why, similarly to how it is the title of the conference today, this crisis, this shortage is what we can observe. And once again, if we look at the data, how many people are 55 plus, then we see that we are third, most experienced country in terms of the experience of our nurses, of our doctors. And that is why we understand that at a certain point this crisis could actually go deeper, much deeper, if we are not observing a necessary replacement. Then there is the Ministry of Economy with their forecasts. They are trying to forecast how much we need, and I think it doesn't even look that bad comparatively to the shortages in other areas. We even see where the areas where the shortage is actually expected to be way, way higher. And if we do then put together these forecasts with the potential graduates, for example, it looks like in healthcare we would even have sufficient specialists, which actually does not resonate with what we heard previously. I mean, probably it's not going to be that positive in real life. But to aggravate this situation even more, or to analyze it in more detail, we need to understand what is going on with human resource availability in our country as such, because in any field, once again, how many people we will need, we look at the demography data, birth rates, and, well, the World Bank also then says that in 2100 there's going to be maybe less than 1 million citizens, meaning that we cannot rely on the fact that actually the amount of people in Latvia will increase, the population will increase. It will not. And considering, because if we see the tendency of the growth of healthcare specialists, well, they do not correspond, meaning that the structure of population in Latvia also has a tendency of people getting older. So on one hand, there are more elderly people, people who need care, and at the same time we do not have enough young people and young people who are undergoing the trainings in the professions that would first of all take care for those who are older and thus ensuring the availability of such services. Then once again, this is the indicator of a qualitative life expectancy, and that is again, we're one of the worst here in the indicators. We need to look at this. It's not because I just would like to be very depressive about this, but in my opinion, upon searching the solutions, we really need to consider all the elements. If we simply skip some and we'll say, okay, we'll try to take care for maybe workload of people, we still see that the amount of people, the reality that is present, what we have, we just can't take it for granted and simply, not expect what we are going to experience in reality. So human resource availability for us, for entrepreneurs, is the main resource. And from the point of view of employees, the healthcare specialist availability would ensure that, first of all, we are healthier, we are more happy, more productive employee, because, for example, in 2023, the employers have paid 4.2 million days of sick leaves, and in the country in general, we see that the increase is ongoing. We have already surpassed 300 million and that is expenses to the budget, costs to the budget. That will also ensure that the GDP will increase, and from GDP then we can devote more funding to healthcare, making it both more qualitative and more available, and thus we will be able to make sure that each of the involved of the stakeholder in healthcare system also earns more.
Arvien vairāk iegulda.
And more than that, more and more investments from the employers are into the health insurance of their employees, and provide that we have access to qualified and capable to work employee. And working in the employers confederation, we can discuss the future of the workforce in general, and comparing it with the health industry, we practically see the practical solutions. They are quite different from other industries, because we talk a lot about requalification. In the health industry, I would hardly imagine somebody who would want me to just go have a short course of acquiring new skills. Also, the other age group involvement as well, taking in consideration how long is education cycle in health industry, there is a low chance that we will use different age groups. Then there's a struggle for workforce, whether or not we will try to somebody to persuade to change the industry. We cannot be so sure about it, because in European countries are in a harsh competition to acquire a qualified workforce. So we at first need to provide the fact that our those who have finished the educational institutions remain in their own home country and continue their studies and professional life in the country they have started their life. And then there are more other classical workforce accessibility solutions, which we in the health industry cannot apply, or can apply in a very limited scope. Therefore, we need to look for a solution somewhere else. And what we do with our confederation experts would like to remark, we see that the maturity of digital skills is higher. So within the industry, we are ahead of many other European countries. Our capability to adapt and use innovations is quite high. It can be very helpful We see that also in operation of Rīgas Tradiņu University, how they implemented in their work. Not to waste time and energy to things that where we don't need to waste any energy. Then there is a list of normative regulations that support us in investment into innovations. And innovations is our hidden gem in looking for solutions. I was part of the work groups to develop the respective legislative acts. And the medical industry often speaks in comparisons where we are with the best practices in the world. And this is an industry we are competing with the best European practices and best in world practices, because in other industries, in many ways, we are much more behind than we are in the health industry. Therefore, we need courage. We need to be very proactive. Because we have enough capacity of talent and will to be one of the leaders in the market. And of course, as one of the solutions are the different AI tool implementation, both in an educational process, so we don't need to do what doesn't need to be done, and also to decrease the working hours for our medical professionals, as well as use these tools on the different stages of medical services like diagnostics and other, and hence use opportunities offered by AI and use the given resource of hours and funds in a better and more efficient way. And yes, and by the way, preparing this presentation, we are getting ready for the Easter and I really like these round and healthy posters in the park. And I wish you all to have this health vessels part. And that's what we work all together for. And have a great continuation of the conference. Thank you, Mr. Zgorsh. I finally understood my issue. Every year I have this round and healthy. I always heard this round part. And thank you. We go on integrating into the Latvian reality. Head of the Professional Union of Latvian medical profession, Mr. Keris. We will use this mic. Thank you very much. Honorable members of the conference, thank you for the invitation and for the opportunity to express the opinion and express gratitude to previous speakers for the fact that I don't need to waste your time to prove the relevance of the topic. I can talk about the matter of the essence, and what I can say today is an annual anniversary event because Latvian government tried to consciously resolve these issues in the healthcare industry 20 years ago, when there was concluded an agreement between our professional confederation and the ministry. So the ancestors of the health ministry, we can express our gratitude for good beginnings. But not everything went as smoothly as it was planned back then, because a beautiful target to reach quickly that the average salary of the physician would be 2 average monthly salaries in the state wasn't achieved. Our professional union has raised this issue year after year. And in this presentation, we used historical slides from the presentations of previous years, both as illustration and also as an informative material. And we can see that in year 2008 in Latvia there was a deficiency of several hundred of doctors and nurses. And unfortunately, in 2010, the situation didn't improve much. Also, there was a financial crisis, and there were harsh lessons left by this crisis. And one of the lessons was what EU leaders were passed over by the World Bank. This serious institution management, those who during the crisis allow themselves to lower the standards in healthcare, get into serious long-term problems. Certain crises also now it's not a financial, and now it's more geopolitical, but this advice, don't touch healthcare, but just the opposite, strengthen it, it's still very relevant advice for nowadays. And I like to say, to express gratitude to WHO, that straight after the financial crisis, there was published recommendations regarding necessity to devote 5–6% of GDP for the health industry. That state has by itself resolved the human resource issues with all available means, including finances. I remember as WHO regional director Susanna Jakob arrived in Riga and spoke with our politicians, with Prime Minister regarding those issues. Unfortunately, the Latvian government ignored that discussion. And unfortunately, even now, in the healthcare human resource development strategy, the increase of the salary is not distinguished. Even if in a future years World Bank observed a decrease of the situation, decreased number of the healthcare employees, and that increased the mortality, avoidable mortality, and therefore Latvia lost and is losing about 4% of the workforce per year. And that, of course, seriously affected national economy. Therefore, there is no surprise that there raised concerns about the state security, and it was expressed by the Chancellor of the state, President of State. And I regret that the state government ignored it back then, and it keeps ignoring even now, because this year healthcare is not in the priorities of the government. A prime minister doesn't connect healthcare with the state security as a strategic component. I hope this conference will change this balance. What was the effect of the professional union on the financing for the industry? There are two of them. First, there needs to be a timeline of increase of the state financing for healthcare in a manner that corresponds with our international partners, European Commission, WHO, and OECD recommendations. And the timeline has to be for the increase of the salaries in the industry has to be fixed, and fixing the financing for those increase. And due to the common efforts, we managed to achieve that time at the end of 2017, adopted a healthcare financing law, and this law, among others, stated two important things. First one, starting from 2022, state financing for healthcare cannot be lower than 4% of GDP, And while increasing of state financing, the salaries are increased to those industry workers who provide the healthcare services funded by the state. Yes, the topic was very relevant back then. And the relevance of topic was proved by the attention of the World Bank and Commission, providing that so far the policy of development of the healthcare resources, and that was due to the lack of political will and insufficient financing from the state. I hope we'll be able to make amends to that as well. However, thanks to some other activities by our social partners, I mean our professional union together with Association of Hospitals, we were fighting side by side. We managed to achieve that at the end of 2018, Saeima adopted a decision by law that 3 years in a row increasing the salaries for the state-paid services, health services, with a significant percentage 3 years in a row. We managed to promote the health salary closer to the average indicators of OECD, and the employees migrated from the paid medicine segment into the state-paid medical services. If this consequent increase of the salaries would be continued, then probably our today's conference would be much more optimistic by mood. But it didn't happen that way. So what are the real average salaries for doctors, nurses, assistants of nurses? You see the numbers? This is more complicated spreadsheet. I will describe what happens here. The average payment brutto before taxes was 3,406. 56% of those were nurses and obstetricians, and 37% are doctor's assistants. The bonus payments is not higher than 20%. That's what the government was deciding back in 2005. In the mutual qualification and proportion of the payments was provided, but what was not provided, but it was the very fundamental thing, which means that the state guaranteed salary level is 2 average salaries in general in the economy. But actual payments, actual salary actually reached it. So it's not state guaranteed, but factually it's been reached. What you should look here for? Since 2014, the increase of the average monthly salary, the actual one for the doctor, or for a doctor, the line about which shows the 2 average salaries in economy, it was reached in 2020, and we could also see that it was strong above this green line, reaching 2.45 or 245% of average. It was thanks to the COVID compensations. Then there was a fallback, and now the average salary is stabilized on average of 2 coefficient level. So what are the average indicators of OECD for the doctor's profession? It's our pink, like it's our utopia now, these 260 points, but it's much better than 10 years ago. However, the state-guaranteed salaries, the red line, hasn't been, the increase wasn't as good. And that's where is a significant deficiency obvious. What kind of deficiency we talk about? Yeah, and then from the negative standpoint, let's discuss it deeper. The main minuses are the difference between actual and the state-guaranteed salary. What does it mean, state-guaranteed? It's fixed in the government regulations, in the tariffs, and is compulsory for the state health service, concluding the contract with treatment institution. The first, there is a direct payments from the patients, and second, there is a funds that have been taken from other expenses for other purposes to provide a sufficient involvement of employees in the institution. And if the first part of money that comes from the pockets of the patients create inequality, while the institutions take the money from other purposes, their development of technologies and equipment is slower. Therefore, it would be very recommended to decrease this margin, and therefore we need extra financing from the state budget, because besides without taking care of the fair remuneration, we won't resolve this issue, because there are two important indicators. Sufficient number of employees, and second, decreasing injustice in the remuneration. What is the number of practicing physicians per 1,000 inhabitants? There are the freshest data, thanks to Mrs. Colombo for their efforts, for that their organization is giving such a significant input in collecting and publishing those data. We see that Latvia, with a red arrow, is strongly below the average indicator. We are staying behind our closest neighbors, Estonia and Lithuania. It's also an even bigger distance is regarding number of the nurses. And putting together number of doctors and nurses, we are in the worst position among all European Union countries. Where does it lead us? In Latvia, in comparison with the average mortality rate, and pay attention, we speak about avoidable mortality. And this context, Latvia is strongly above the average number. The difference is about 350 died people upon 100,000 population. That means they could be saved if we would provide proper health care. And it means that as a country, we lose about 6,500 people, which is a huge loss annually. And we have to avoid those as quick as possible. Without respective financing for healthcare, we cannot resolve this. What was the tendency in the last 10 years? We can see that ever since 2019, the financing has reached and slightly over 4% of the GDP. And that's exactly the effect of the state health financing law. Unfortunately, this year there is an initiative to cancel this limitation. It's easily to understand where does it lead us. Bearing in mind previously shown avoidable mortality rate. And at this point, the concerns have been expressed both by European Commission and OECD in their reports about Latvia and their recommendations to Latvia. Unfortunately, Latvian government is ignoring this. There is no intention to increase the financing for healthcare. There is no intention to increase the salaries in the industry. So we have to face the question, who benefits from that? Those who are in this room certainly don't. What the doctors themselves think about the situation? Latvia is a small country. And then there is a big country, another big country, USA. Talking about Latvia, we have opinion of young doctors that was gathered in the research survey. 3 main issues to resolve named by the young doctors are this increase of the salaries and increase of financing for the industry in general, because those 3 are directly interconnected. The opinion of doctors in USA, it comes from slightly different survey. That's why the questions are quite a bit differently put. But one of the main medications against the burnout at working place is increase of the salaries. And second is increase of the support personnel in the healthcare, because we know how much we miss a sufficient number of nurses. Then we can imagine how much higher is in Latvia the professional burnout risk for Latvian doctors. What would be our professional union recommendations? First, it would be in the financing law, we would include the timeline according to which this financing should increase up to 6% of GDP, just like the state security law, defense law, and also by regulation of Cabinet of Ministers, increase of the salaries to reach at least previously mentioned indicators. And for the end, I wouldn't suggest too many hopes regarding digitalization, standardization, and similar things, so that we wouldn't land in an unpleasant situation than this. Thank you for your attention.
Thank you, Mr. Keris. Now, this session of the report, we're going to finalize with Madame Kļaviņa and her speech on the perspective of the Ministry of Healthcare for the strategy of workforce for 2029. Hello, dear audience of the conference. This is a worrying moment. We are responsible for both organizing this conference, and it is a significant point and conference, and I have during my career experienced several ministers of healthcare, and this is the first one to organize a conference on workforce. It is important. Workforce is mentioned often. We're talking about queues and quality. But as it was discussed during the first panel, how are human resources the priority? And for us, as policymakers, how big this is the resource and priority working with these things. My task today is to tell you about the human resource strategy briefly, which at the end of last year we did approve on governmental level. This is the specific slide. I think we've seen it during the whole day already. But the main message remains that the supply of physicians and other specialists is insufficient, especially with the tendency of specialists getting older, and regional distribution is unequal. Primary care, available services, emergency services, equally spread throughout the territory of Latvia is the main direction and the problems we are looking at. However, the doctors up to 35 years of age in Latvia during the last years, it's been like an outburst, and thanks to the budget, thanks to the universities, we are increasing the number of doctors. But as Thomas said also during his presentation, that this is one very important measure. Nevertheless, it is also important to see where they are working, where do doctors go afterwards, how and where they will be able to apply the knowledge they have obtained. And also, as it was said by someone at the beginning of the conference, is that the human resource planning preparation is, or it takes very long time. We can't just at any given moment to receive so much human resource in such amounts that we need today, and additionally we also need to look into the future. Then there's also OECD, which shows clearly and confirms what Mr. Keris said and also everybody else, that the investment in human resources is not an objective in itself. It is related to public health. It shows correlation between quantitative and also mortality ratios. So the less human resource availability is or supply, then the worse are indicators of mortality, unfortunately. Yes, indeed. We were also in the photography, which Thomas showed. The colleague signed, yes, the Bucharest Declaration, the large one, on this large poster. And it, for us, as policy planners, ministry officials, showed us clearly that the human resource matters is not just about the study placements, about the salaries, which is, of course, critically important. But we need to remember the work environment and the capacity of the healthcare professionals to even work. Through discussions with all of you, we have discussed, and we are accustomed to in the society thinking in such a way that whatever happens in the world, in the country, there will always be some professionals of healthcare. If there's crisis, they will be burnt out. It would be difficult for them, but they will be somewhere. They will always be somewhere. And in the declaration, we see it stated clearly that we shall not ignore the fact that healthcare professionals are people and significant, important part of our society. We have been working, we have taken into consideration the action framework on the main directions. As the main directions, we chose the approved document for health sector main directives and guidelines. And with European Commission together, we had a project that assisted us in development of the framework strategy more in depth. And which is also important, upon development of the strategy, we considered the survey of the new doctors in Latvia, and also about the nurses, the data about the nurses. Why nurses, medical nurses, choose to stay in the industry, or vice versa, why they are not working in the industry. These are the papers we worked on, and the strategy is a 3-year document, rather compact. It's more like a roadmap for us and for our ministry and for our cooperation partners, for us to have a mandate and authority to know which or what we are working towards actively. And I would like to say, to work. Indeed, one of the speakers previously said that the plans and the documents are not the ones to solve the situations. It is important to these undertakings, these commitments to actually apply, to realize, implement. And so the utmost goal is to ensure the necessary human resources for the industry, both qualitatively, quantitatively, and efficiently, as we heard today. It is whether we are using enough the competencies, the skills our human resources have, our workforce has, the specialists, how much do we manage for them to do, what they are not supposed to do, meaning maybe some administrative work. So that is the direction we should be looking at. And then we're also keeping those 3 main positions. Is this insurance of the replacement, and also one of the colleagues said that it is important to see our golden fund, the people that in the system already currently. We shall not ignore the huge contribution of these people, and we need to take into consideration their conditions of work and remuneration. We need to be thinking both about the people who are in the system and the young professionals who would then ensure the replacement, and we would like to see their growth. So optimization, meaning, as I said, the skills, the efficiency, creating the diversity. In human resources, we see that in the system there are ever more non-medical competencies that are even necessary that could then unload the burden for the healthcare professionals to be able to realize their professional activities. And to strengthen the human resources in healthcare, strengthen the system in general by ensuring the readiness of the system for various crises and situations. So the strategy then is directed into these 3 directions. First is planning and funding, which is investment. Second, education and employment. And third is work environment and performance. So we have the registry of healthcare professionals, but we do understand also the necessity of being more modern. We need information system where it is not just authorities, officials putting in data. We need it for example, to see if there's data in one medical institution that they are already registered there, then all this data comes together in one registry of the state, and it shouldn't actually be just replicating, or this activity should be done once more to register the person. So it would even be like a real-time model. We have also to continue and exchange experience with other countries where it is never-ending story on where the improvements can be done, and also development of the human resources in general. We are happy to see that there is funding available and for human resource research. Now, education and employment. There, it is the contents of the education where the curriculum corresponds to the labor market demand, more flexible education, form introduction, and then also postgraduate, which in this case would be the regulated profession, meaning the healthcare specialists need to re-qualify. There are certain conditions they need to fulfill, and we need to ensure the mechanisms for this postgraduate education to even be available and valuable, worthy. Then we're talking about the cooperation with Rīgas University and the University of Latvia, the direction which we see in our strategy too. The work environment and performance. This is exactly the flexible working hours and shifts, the work environment as such. There's a question that is topical about the violence in the workplace. I mean, matters that we have not directed our attention to very much. And the incentives. Definitely so it is the salary. But in the strategy of workforce, the government has committed itself to work and fight for the increase in salaries for healthcare professionals. But unfortunately, in this strategy, we couldn't put in concrete particular percentage points or numbers that would then reflect this commitment of the government. And let's just say the strategy, it is not just a blank paper that we sit at and start writing. No, there are several programs and policies that already historically have been present, and COVID time, for example, was the challenge for all of us. In a way, it made us all stronger. We were able to introduce certain solutions quicker. We have created the system societies where the healthcare institutions, and in particular the hospitals, are putting in certain operational data, and then there is also data on human resources, and that is the national national data system where we can see the employees in terms of the workload, because in the register of healthcare professionals we simply have the list of people working. And once again, I will just mention that there are opportunities for improvement. However, this is what we can begin with. We are also planning using it for residency planning and also in other contexts. The critical situation with the supply of medical nurses, we have been very active. Introduced also the general medical nurse specialization for the nurse to be more mobile in the labor market. And Rīgas University has created a program. We have approved the profession standard. We are going to start now admissions into an increased, so advanced nurse profession. At the end of last year, we did adopt the regulatory acts that give opportunities for nurses to also prescribe certain medicine. Does not mean, though, that, and there are myths and legends, that actually nurses are able to prescribe anything at all, and then everybody would be just, proceeding with doing it so very much. But no, if we're talking about certain drugs, then this is, of course, in cooperation with doctors. However, there are cases when such powers are given to nurses. It is improving the availability of services. And also midwives and their competency. Then we were talking about certain study changes, professional and postgraduate studies for doctors and nurses. That is another exercise that we will hopefully introduce with the colleagues, that the doctors, when they're in residency for already subspecialty specialization, for it to be included in postgraduate education more flexibly, for the doctor to be able, during the studies in the general specialization, they could then obtain another auxiliary specialization. And then the second planning period introduction for European Union structural funds in social fund. And we have this, once again, postgraduate education measures included, 58 programs, as you can see, and so many people undergoing the studies. But as I said, our aim thereby is to create this program in such a way that it is more coordinated and valuable. And what Mr. Minister said also, these attraction measures, and what the Minister said, that from day one, unfortunately, from day one, in this, regarding the situation in Ukraine, we have done all that we can to provide support, and also to provide support to healthcare professionals from Ukraine and let them work in their profession, which in turn then also contributes to our healthcare system, which we are very grateful for. And then the last slide, I am a public official. That is why I have written down, of course, the informative papers here and maybe the rules of the Minister of the Cabinet of Ministers, but still, I would like to then just highlight several measures we're going to be working on during the next 3 years. Is the matter of salary. Very important one, and we hope that this conference also contributes to this road to the Minister of Finance and Government becomes shorter. In any way, we are implementing this into the regulation, that with the increase of the salary, it is very important to increase specifically the lowest salaries. And then the reporting system on the cases of violence. As from the survey, once again, we see, thank you to junior doctors, that they are brave to draw attention to the problem of violence, that is both violence, patients, close relatives and acquaintances of patients, and also among colleagues. It is maybe something not being debated often. Well, we will try to create a system like that, and also primary healthcare team strengthening. And I think that one of the big challenges will be the flexible working hour assessment, or possibility assessment of the possibility, what we can improve to improve the flexibility. Then payments for the services. One is once again salaries, another one through payment for the services, to ensure that for service provision they would have in the necessary amount and in the necessary competency the personnel which is being remunerated accordingly, for them to have a larger interest, larger motivation to even provide the services. Because we see specialities, we see where it is, for example, possible to receive a better salary, but there are such fields where it is not possible, and that would be one of the measures. And health insurance for healthcare specialists, it is something to consider. Thank you for your attention, and only I wanted to say in the end that cooperation indeed is a very important aspect, not only in healthcare, not only in other fields and internationally, but next to this word cooperation I will put the word courage, because it is easier not to do, to save ourselves, so to say, but we really need courage to step up and do more. Thank you very much, Madame Kļaviņa. And so, to just remain in this rhythm of our conference, next we'll see the panel discussion. We are going to accept questions from the audience. We'll be able to answer the questions that have been sent to us previously. But now, short coffee break for 15 minutes. 15 minutes. We decreased the time for the coffee break. So at 16:05, we are back. Back here in the room.
Particular moment, 15 minutes and a bit more. Brīnišķīgi, un mēs esam gatavi turpināt mūsu noslēdzošo.
Beautiful. So we are ready for the last stage, for the last session of today, and look into what could be the solutions, what we are doing tomorrow for to to fight the crisis, to overcome this challenge. And so now the panel is going to be speaking, of course, in a language they feel necessary or that is convenient to them, and that is what we can do. And for those remotely, then again, I see the minister being back, and everything is once again serious. So let us just welcome with applause Augsta Valiniene, State Secretary of the Ministry of Healthcare of the Republic of Latvia.
Again, our colleagues from Slovenia, Ministry of Health, State Secretary Denis Kordež. Welcome back on the stage. You all already feel comfortable here, I believe. That's very good. From Montenegro, State Secretary, Ministry of Health, Dr. Milena Kojic. Welcome. Cyprus, representative of Ministry of Health, Angeliki Protopapa. Hello, happy to have you here. Latvijas ārstu biedrības ētikas komisijas priekšsēdētājs profesors
Vilnis Lietuvietis, Chairman of Latvian Health and Social Care Workers Trade Union.
He's here. Welcome with applause, Francesca Colombo, please. And there are kind of traffic jumps in the city, and a lot of you have to plane to catch. So we made an inner decision and conclusion and promise that we will go out from this house all together around 5 o'clock. So let's not take it too far, and also ourselves, let's be in a conclusive way. We will start with a Latvian perspective, Latvian Ministry of Health, Augsta Valiniene. The question is, where do you see the role of institutions, of employers in development of human resources in the healthcare sector, and what's on your table as the first steps to do and the most important? Var tagad runāt latviski, jā.
You may speak in Latvian also. Thank you for the opportunity to be in this panel. This is like a lesson for us organizers. We maybe had to actually organize this panel before the previous speakers, because the previous speakers did answer all the questions what to do, basically. We can just simply take a checklist and mark it that this is done, or this is done. What I can say, and what is on the table, on the agenda of our field, and how we see this from our perspective, that at times also was heard from the presentations, is that maybe somebody is for the first time in such an environment, or maybe there's another ministry that must be present here. But a very significant aspect here is that we shall work together with various sectors. Long ago are the times when we have the privilege to be talking ministry with doctors, ministry with patients, only certain organizations with ministries, etc. And that's all. And then we would have like solutions. This problem is long-standing, but now we are looking at it in a more multi-sectoral and multifaceted way. We finally, and that is why we tried to invite all the specialists as much as we could for the conference, for the panels. We asked parliamentary representatives, all the politicians. We invited all the ministries, part of which are also here in the audience or listening, because seeing the figures today, and we paid attention, we looked at it, and us working in the field of healthcare, the perspective and the situation is not optimistic for me. It is rather adverse. We have a country with these demography issues low birth rates. We know demography is not something that tomorrow we are going to get the medical personnel that is capable of working. So there are such issues, and they are so much multi-sectoral that even if we had a magic wand, even if we had the funding, everything they're asking for, the accessibility wouldn't change, because we have the specialists, and I think Dr. Zapata was talking about this demand, the increasing demand. And that is why I believe that it is an intense and even more so intense work with so many stakeholders. Of course, we should continue also working with our partners we already have, like associations, and including of the WHO representative regarding the demand, what was told, the education, but not only, there's also a story of the quality, because given the amount of the demand, where ever-growing tendency is to demand all kinds of services and everywhere, today it no longer correlates with the service security and quality, because we are not able to ensure this. That is why, once more, and in a very brief, concentrated way, we're short in funding, and we need to be working with expanding the competencies and flexible decision-making and developments. We have to be working even more through all sectors cooperate in cooperation. And we need to honestly say this, that one of the speakers previously said, honestly, we need to acknowledge what we are expecting from one another. We shouldn't blame, condemn anyone, but there are homework on all levels. And this is for professionals in healthcare, for associations, in local governments. Politicians have their homework. Everybody has their homework to do. Thank you. This message is clear. So cooperation among the sectors now.
And the question is the same, but a bit of continuation of what was said before. Where do you see the redefinition or redesigning of roles and of stakeholders within all the system, not only healthcare system, to cope with the issues and challenges we are discussing today?
Well, thank you, and thank you, Agnes. I actually cannot do nothing else than just to say, yeah, checked. You said it all, almost all, because it's we can actually leave early than 5 p.m. No, seriously, we have to be honest. Like I mentioned before, not just Slovenia. I believe that that is the case in all or most of the other EU countries. We neglected past years regarding human workforce, health workforce. So now we struggle, and like it was said a few times today, even though our numbers are actually increasing in human workforce, health workforce, sorry, we are not reaching the demand, which is increasing even faster by aging population. So all of the measures that worked in any country, you have to try it out. You have to strategically plan. You have to have focus on what is happening in your country now, what will happen in short, mid, and long term. So in order to do so, you have to cooperate. So if you're asking me, what do employers, institutions, and policy makers have in common, or what should we do today and tomorrow, we have to stay strongly connected. Our measures have to be strategically aligned, because we are in the same boat, not just healthcare system, because in Slovenia we are facing shortages in employees in all other sectors. I believe that this is the case in many of the other countries. We have a recordly low unemployment ratio in Slovenia. So what are what should we focus on? So definitely one of the actions that has to be taken is in the field of education and training. It has to be flexible. It has to adapt to societal changes. You know, the younger generations are looking differently at their work-life balance situation. So this is one of the main things that this old-fashioned orthodox system has to change and it has to adapt. A career development is something that wasn't heard among healthcare professionals. So we have to adapt to that doctors may want to make changes in their careers. So in this field, we have to make some accommodations. We have to adapt to that. So maybe this is something that we also neglected in the past years, because everyone was talking about it, but we just didn't want to hear it and to accept that. So of course, constantly improving working conditions. This is one of the main areas, and focus on well-being, because again, well-being of individuals is even more important now that was before. And ensuring, of course, financing and infrastructure investments to have enough infrastructure to cope with demand, and maintain, like I said, a strong and ongoing cooperation between policymakers, politics, educational system, and of course other stakeholders, employees, and so on. So this is core.
It. Yeah. Thank you very much. Madam Koch, continuing the same train of thought, the question, not to repeating and saying everything is already done, how, from your perspective, Montenegro, how do you expand the idea of healthcare outside of healthcare? Because we are speaking here about different sectors, about that social sector should be more involved, and educational sector should be more involved. What's your experience, how you are getting out from, there was a long time ago, one conference in Latvia where one of the doctors said, please raise the hands, everyone who is from the health care, and everyone's raising the hand. Is there someone outside healthcare? No one is raising the hand. And then he said, we are medical sector. How to get out of the sector? Because we know what we speak. How you get the message out from the healthcare to others?
Well, that's a difficult question. Very difficult question, because I'm a doctor and I wanted to tell you about a little anecdote. It will take only a minute if you can listen. I was working in the field of family medicine, and I had a pretty much low salary, and I wasn't happy because I was overburdened. I was happy with my personal life, but unhappy with the professional life. Then time changed, and we all faced bigger salaries, but we remain unhappy. And wherever we gathered, we were talking about administrative burden, about violence against healthcare workers that we face every day, about that even even when we are sick, we still come to our job because there is no replacement for us. And that was the big motive for me to come to the to come to work as a state secretary, to the less salary, but I have a opportunity to change something. Now I'm battling Ministry of Finance, I'm battling my colleagues in Ministry of Health that are not doctors, that usually don't understand what we are talking about, because we are pretty much high achievers. We are raised at same level, so I think we should more act at community level. I think we should be one with our patients, because our patients are from various fields, and they are the only people that can understand us.
So before reaching out to get the order in your own house, feelings and community, that would be the message.
Yes, that's my message. Maybe it's not true, but I think that's the only part right now, because last year we had increased salaries, and the amount of media attacks was enormous. Look at them, they're not doing anything. Yeah, and when there was a COVID, everybody applauded us. In every day, at 8 o'clock at the evening, everybody at their terrace applauded us. But when COVID finished, our parliament voted not to raise our salaries. And when I was at the market, my husband said, okay, now pay these groceries with applause. So they don't understand what we are doing.
Great example. Thank you. Thank you very much. We are continuing, Madam Protopapov. What's your perspective on the most important issues here we are discussing and reflection on the day?
Hello, and thank you for having us. I think this is a very meaningful meeting in terms that nobody of us don't know what to say because everybody has said it all, but still, if you spot on the fact that the ones that they are in the healthcare sector, they know their problems, they are trying to deal with them. That's why we're having this meeting today. That's why it's an important meeting with all the ministers and all these countries and their representatives. But still, there are more people, as you said before, that they need to understand what the healthcare sector means. It's above, and not only we're talking about, and before they were talking about the buildings and the doctors and the nurses, but it's also about the education, continuous professional development, the well-being, mental health. Before COVID, these issues weren't erased. Maybe the people were embarrassed as well, but they weren't so talking about burnouts. But maybe COVID gave an opportunity for the health workforce to say that, yes, we have some problems, it's time for you to deal with them. And not only in a financial matter. So, and in terms of the first question that you did about the employers, yes, it's safe, it must, for them, they have to create a safe environment. A safe environment in terms of, yes, salaries, training opportunities, professional growth, development, and people to feel, as you said before, the financials with the parliament that didn't agree, but people need to feel respected and supported. Financial, technology, and we can see people in the parliament can be tough, but the people outside the health sector, like the Ministry of Finance and everybody else, they can be tough at certain times because they cannot clearly understand what we mean by primary care, let's say. It's another issue that eventually, and the economies and the system can, of course, save up money, but first you have to invest money in order to be able to save up. Thank you.
Thank you. Thank you very much. Raising, in fact, awareness within any state and any governance around the healthcare system and its role. Thank you. Madam Colombo, you're smiling. I feel you have something to say. The floor is yours, yes.
Thank you so much. Maybe some reflections I wanted to say about the Ministries of Finance. Because we had somebody, a representative actually, I think at the very beginning, but then obviously no more. And it's true that when we go to conferences, they're absent there. And still we keep on talking about that. I wanted to reflect because we do have at OECD actually network of Ministry of Finance and health officials. And I tell you, the demand to set up this network came, yes, from the Ministry of Health, but also very much from the Ministry of Finance, and I'll tell you why. Because they were telling us, we just don't understand the health sector, but also you are very siloed, so it makes it quite difficult for us to help you in a way. And they were saying, look, the jargon which is used is very difficult for Minister of Finance to really understand, or even talking about qualis, dalis, some of the things, you know, it's just not immediately understood, or medical terminology is not immediately understood to Minister of Finance. And I think that's, for me, it's quite important, because of course we want to make sure that we get more money from Minister of Finance, that's, you know. But I think we need to understand that they're also trying to do their job, and perhaps we need to find ways to communicate better about where there are opportunities which are win-win solutions. So where there are investments that would deliver long-term improvements, including in the cutting of waste and inefficiencies that they care so much about. And I think sometimes we are perhaps ourselves not realizing that we need to speak their language much more. And the same applies actually when we're talking about cross-sectorial collaboration, which is crucial if we're talking about a future health system which will be more about prevention, about anticipation of needs, about reducing the needs for health care. Well, that will require talking to Ministry of Agriculture, which could have different objectives from Ministry of Health, you know, Ministry of Education, of course, you know, all sorts of different ministries. And sometimes if we go to them and say, well, we need to have health in all policies, they say, why not education in all policies? Why not agriculture in all policies? So what are those win-win which will be good for us as health, but also for other sectors? And that's where we can focus the discussion conversation, because there are many of those win-win, and we just don't bring them enough to the conversation. And they are obviously about, you know, healthy eating, you know, they are about activity, they are about climate change and health and things that can be done, about changing the environment, the urban environments, and so forth. So there are quite a lot of things. I don't think we do that enough. So perhaps my plea at the end is just, obviously we need to argue and fight strong for the health sector, but sometimes we also need to think, perhaps put ourselves in the shoes of others and try to use their language to obtain what will be those win-win.
Thank you very much. I believe we are already, Ministry of Latvia can draft out the next conference with other roles included, and that this idea is pretty interesting, where to find the common ground with all the sectors, because health is in all policies, but all policies, they largely don't know that the health is there, and there is a place where to find it. Thank you very much. Professors Vilnis Lietuvietis, ārstu biedrības ētika.
Professor Vilnis Lietuvietis, head of the ethical commission of the Physicians Association. Good afternoon. Thank you for the invitation to be part of this conference and be here in this panel discussion about the, today's most relevant topic. You know, those who don't know Latvian, I should say that my neighbor, my surname is Lithuanian. I'm Latvian with a surname Lithuanian. So every time I cross the border, I see that they give me a special greeting as a Lithuanian, but I will speak Latvian. Anyway, I represented doctors. I am in the managing board of the Physicians Association, but my daily work is I am managing biggest urology clinic in Baltia and Latvia. And when there was a crisis in 2008-2009, we knew that every crisis is an opportunity. We used this opportunity very well, I believe, because from 4 departments in 1 hospital, we created 1 joint clinic. We reduced the beds from 140 to 60. We increased the efficiency, and within those 14-15 years, we had some achievements. In our clinic, there are 20 doctors and 8 interns. And from those 20 doctors, I was looking for a proportion, 50 plus. are only in 25%. The rest of them are young doctors. And at the same time, as a head of this clinic, I'm head of the internship program in Stradiņš University, and I'm quite proud that none of our young interns have went to work abroad. They have all remained in Latvia, and I believe that's one of the achievements where we facilitate the change those 15, 16 years ago. That's a significant achievement, I believe. And what should be done further? In fact, we further should talk about the financing. A few years ago in Latvia, there was a discussion that Ministry of Finance and politicians expressed, hi, you should do some changes, some reforms, then the money will follow. In the reform in the health industry, we did the reformation of the industry, but the money follow-up was a bit of a struggle. And that's an important moment that those young doctors have to see and have to trust that when they change the system, that the life really will follow in changes, and they can self-realize it in this profession. Yes, salary is not the main thing, but it's a significant factor. We will talk about it later. When they see that the transformation is followed by innovations, then they certainly want to be on the same level, on the same technology level with other big clinics of Europe. Today, recently was the European Urologist Congress, and 2 young doctors were part of this Congress in a panel discussion for 15,000 specialists from the whole world. And that's a really, really great achievement. If they can see that we can do that, that we can develop the technologies and go on such world congresses and say, look, we do have these same technologies here. And not we just look up like, okay, we will maybe be there in 20 years. That's an important incentive for young people to choose this, their own land and to develop their potential here. And we know that demography of birth is quite low. But how should we encourage birth if the family cannot support those 3 children? So these young people who, for instance, in my clinic, they are 30 to 40 years old. They are in their fertility age. I said, your main state mission is to have 3 or 4 children, but we would need more salary. And the professor said, okay, I promise I'll go to the conference and get you more money. So to support 3 children, they need a fundamental foundation, and that's where we need to work efficiently. So all these topics are strongly interconnected, both the finances, and the labor and the efficiency, and the number of children in a family. Talking more about the education, I think there are amazing tools like Erasmus program, and our young doctors for sure go to the leading clinics of Europe, Bristol, Munich, London, and so on, Milano. In Rome, there is a young colleague, and they bring home the knowledge. When they bring the knowledge home, again, there we need an investment so that those fresh knowledge they can implement in their daily life with their patients. Otherwise, there, in theory, everything is so good, but we cannot afford the technologies, and we are dissipating these knowledges. We need the acquiring knowledge. We need to follow up with the technologies. Talking about the finances, it's a very important aspect. Like a week or so ago, Dr. Sipol, she gave an interview after visiting Ukraine. At the same time, we saw that the emergency aid financing is decreasing. First of all, fully cover the emergency aid, because it's crucial question for the state security. It's a strategic question. As our minister mentioned, if people want to get a possibility to stay alive in a hospital, if they will be after some accident, then investment in the police and others makes no point. Because, of course, if we will catch some criminal, okay, police will catch them, but the victims, they need to know that somebody will save their lives. And that's our ER departments in hospitals. So this victim has to know who is waiting for him and with what is awaiting him. Like 5 years ago, because COVID, we bought 5 diagnostic tools. We upgraded our computer tomography and X-ray. We had 3 computer tomography machines. We could sort out our patients with all the COVID issues quickly and efficiently. And those 3 machines were working non-stop. And before that, there was a big discussion in the state. Why do we need it? Because they provided this ER, this emergency aid efficiently. And if someday the X hour will come, and these ER doctors will be first who will work with victims, whom we can quickly retrain. We should train them actually today, so they are ready for the most serious emergencies. So those are my main considerations, and to achieve it all, it's very important to change our way of thinking, that changes are constant. We need to think, what shall we do tomorrow, not what we have done yesterday. And also, I would like to express gratitude to the fact that we develop our new technologies. We have now a robotic project for surgeons. Let's see how it will be financed. I'm for sure it will have great results. And again, these new doctors will see that they have the same technologies as other doctors in other countries.
We have close cooperation with centers in Copenhagen, and that is where we also, that is one of the cooperations where we gain this experience. And I like this sentence of one of the professors I heard in one of the conferences, that coming together is just the beginning. That is why I would like to express gratitude to all the ministers and delegated representatives who have come over to Latvia. And the idea itself of coming together of small states is indeed something we should applaud, because the small countries need to agree, harmonize, and develop their vision. Latvia and Lithuania is never going to be as the UK, as the France, and we need to exchange our ideas and thoughts and develop our own mechanisms. Thank you to all of you. Thank you to all of you present. Thank you to the guests and everyone, us discussing, sharing the knowledge, coming together. And then we go working. So that is why I wish us all a successful work for the next, years, let's say. We'll not say how many, but years. Thank you, Mr. Professor. Professor, you actually concluded the conference, I guess. Sorry. I'm sorry. That was unintended. I actually wanted to warm up, like an attempt.
Yes, indeed. I believe we, in this panel session, without any pre-drafting on scenario, in fact, we are building the agenda for the next meetings in whatever form they're going to be, roundtable discussions, conferences, dialogues, or maybe even some conventions. We're going to see that. But taking into account the first round we discussed through, if you are okay with that, and if you vote for that, I would give now the floor to Minister, round all this up, because in my experience, Minister is not short talker, and he has always something to say. You can stay here, because that will be like that he's not just alone, because he's a bit narcissistic, so all together is always good. I'm just joking. Please, the floor for the Minister, and a round of applause.
Thank you very much. Jā, paldies, kolēģi, tiešām.
Thank you, colleagues.
kā Mārtiņš teica,
And as Mārtiņš said, the moderator, I will not be speaking for long, just 15 minutes probably. Today we talked like out of the box, in out of the box format. We were very open on what's going on. And I'm very happy that followers on Facebook and somewhere else, they wrote us a question or a comment. They said, oh, it's just blah, 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 and then we go home and nothing's going to change. That's not true. Not from my part, neither also from the part of the colleagues, as I know, because without people, there may not be any actions. And we are people, and without professionals in medicine, there are no institutions, there is no infrastructure that needs renewal and no hospital beds. I think that for everyone it is clear today that funding is at the forefront of everything. That is like a special #1 matter that can solve any plan that we write, any strategy that we submit to the Cabinet of Ministers, but just without the numbers. And then the confederations of employers or trade unions don't understand why we would even need such strategy. How is that a strategy without certain numbers? I agree to what partners talked about today. I couldn't hear all the presentations, but I agree even without having heard the presentation. For example, specifically from trade union, yes, it's fine. I think that human lives are so much more worthy than any material possessions. So funding, what does that mean? That means salaries, of course, #1, but it also means the environment where healthcare professionals are working. As Mr. Professor Lietuvietis, meaning Lithuanian, but who is Latvian, as he said today, that there are new technologies and development of technologies and modern methods for treatment is important because healthcare professionals working in small countries, they want to practice in it. And if they can't, then they are seeking some larger countries, bigger markets where they can practice it. So we are here in Latvia, and I think that in other countries also, there are such technology. And we were in Stradiņas University Hospital. We showed our colleagues what we have. We have everything. We have everything that is needed for our new doctors to stay here in Latvia and develop their skills and expertise. Healthcare professionals need both remuneration for them to also support their family, and then they are in a good financial state and contribute with their utmost valuable work, knowing that, as colleagues also mentioned here, that they applauded us, yes, during COVID time. Exactly. This applause, but it wasn't on our table, right? So it wasn't just another liter of juice or something we like on our table for us to survive. But anyways, we know that medicine, healthcare is a mission. And we had worked, we are working, and we will be working in any conditions, regardless of whether we are going to be paid. And yet we have also families, and we need to grow the new generations of healthcare specialists. In Liepāja, a colleague said that there's young people preparing their applications to study medicine. Very nice ideas we heard today, and also during lunch with Stella and Clinic in Vaivari head. We talked and with many other colleagues that they're going to prepare some informative campaign and materials to distribute, which then means that healthcare professionals can also get involved. And not even looking at that, we have now new budget placements, 150 for higher education for medical nurses. No, but we should also involve this person, meaning last year there were, for example, 55 paid family doctor vacancies, I think, 45 or 55. Now 10 places were vacant. So we can't even convince people undergoing this training. And what they're doing in Cyprus is very well. We're going to take it into consideration and try to also implement. Also, what is important, the idea we heard today is flexibility in our regulations. We are changing, we are adopting, we're going to be trying to change and adopt and trust each other more. So a nurse, assistant of the nurse, and other roles are necessary. This profession of nurse needs to become more prestigious. We have this problem that sometimes people just want to go to a specialist. They sometimes don't even go to family doctor, general practitioner. They go to the specialist themselves, and then they are even advising that specialist what kind of treatment or what kind of tests they need. We need to look broader. We need to go to the society, spread the message that we are in a state that not always are we able to get in certain regions some specialists, but we have there assistants, we have nurses there and other practitioners, and there are certain roles that are available there. And so that is why we have also adopted the amendments to the rules of the Cabinet of Ministers, where we are now saying that nurses and midwives can prescribe certain medicines, certain drugs that are currently done only by physicians. Also, last year we allowed and we trust the students of 5th or 6th year, not as before now, up until now, that they are working, I don't know, in pizzeria or restaurants in summer, that actually these are professionals, almost doctors, who can be trusted and under supervision if they work in hospitals in Riga and also regionally and in local and smaller hospitals. We have changed that last year, and we are continuing the cooperation with the Association of Junior Doctors, New Doctors. Also, together with universities, we work to cooperate and to improve the education of residents, but not only for the residents to go to larger hospitals, but also in regional and smaller hospitals, because maybe afterwards the specialist can stay there. That is one more matter of cooperation. And in cooperation with municipalities, for example, we could then have additional support, also funding for this specialist to stay in the particular local government area. Also, cooperation among the ministries. We shall strengthen the STEM field. I don't know how it is in Cyprus or Slovenia or Lithuania or Estonia or in other countries, and what is going to happen with the young people. Do they even want to study biology, physics, etc., or they're just, or not just, but are they going to another training? It's like, for example, when you are in grade 9, through teachers, maybe there's some kind of we need to convince them somehow, or maybe there are certain professional organizations that go then and spread the message about certain fields. I don't know if that is also practiced in other countries, but we have such day of shadows where school children can participate, can follow, be as a shadow of some professional, and there were examples of such shadows for healthcare professionals. So we, once again, we need to be working on this in this specific campaign, well, you know, because politicians are very popular among these shadows, but then we need young people to go to policemen, to also doctors, the same. And we should offer something more attractive because, you know, pupils, like, for example, my daughter said, well, I wouldn't want to go to the teacher, right? I wouldn't go to school. But then I would just go and walk around. But this day needs to be somehow fulfilled. And I also think that it is important to talk about the role of digitalization. Today we did not stress it so much. And again, we're not talking about maybe firing, making redundant certain persons because they are not necessary, but the technologies are very quick quickly developing, and we had a meeting with the Baltic States ministers and the World Health Organization. We were talking about the importance of AI and how it is being done a lot, or many functions are being taken over from doctors, from nurses, and they have to be working more, not answering the questions over the phone. And then AI could be the one to assist for the person to maybe schedule their visit at the doctor, and maybe certain recommendations even can be given with the AI for the patient to improve their health condition even when they are at home. Also, we launched in Latvia it's like a hospital at home initiative, which was, well, it is a really good work that that we conduct together with the university hospital, Rīgā, together with the rector of the university. That was last year in Baltimore when we were there. We stole 2 ideas, and Slovenia started doing it, implementing it in Estonia. There's one idea, like advanced nurse idea, and this year in September, we're going to launch this program. There's going to be 32 places there. Well, exactly, that is at least, or that is the beginning, because the advanced nurse program is, it is for, the graduate will be a nurse with her practice and even consulting, and then you could even go to her and ask maybe if you can schedule certain visits regularly, maybe, I don't know. But this, we are not excluding anything in this healthcare field. We are applying something and very targeted, in a very targeted way, to reduce the workload of professionals, reduce the administrative burden, and for them to be able to meet more patients and provide the best service possible. Yes, we did talk about salaries. Yes, we did talk about people, but we did not talk about quality. However, quality also is an important matter. Everything we did discuss today, if we can't provide a secure, qualitative service, we're going to lose the lives of people. And the more there are such problems, the more there are challenges. Something that needs to be fixed, not only, and it can not only be fixed by with the money, but with service quality. So here again, we need to balance through efficiency and service. I may continue, probably forever, but I guess it's just 3 minutes left, so I see all of you. The most durable ones. I will just continue that, and with Martin we discussed. Actually, next year there's going to be this event, number 2. I see now Mr. Sayes, but he's also tired because he was one of the organizers, and I know he's capable. Thank you, Normans, from my office for involvement, but the most gratitude to the Ministry of Healthcare of the Republic of Latvia, beginning with the State Secretary, because, and this special department, this special unit, my perfect servicemen, nobody sees, because they're always somewhere in the background, but they work 24/7, especially during the last days, because they have not an active minister. The minister doesn't get involved a lot. So, once again, to all of you, I will not just list you all, but really, thank you so much. What was the name of the department? Title of the department? European and International Relations Department. So once again, thank you. And everything that was going on here today was thanks to your work. Of course, gratitude to my colleagues, ministers, dear colleagues who could arrive. You know, Actually, initially we thought maybe this will be the, at first, national level, Latvian level. But then at some point I said, no. I have colleagues, especially from smaller countries and ministers and also representatives with whom we have cooperation. And so it is 6, 7 countries. Malta wasn't in the panel, but it's somewhere also in the audience. Thank you, Malta, for participating. And then next year, if we will launch earlier, then we will have even broader representation and audience. Then next year, we're also planning to invite small countries initiative. It could be 15, 20 states. So next year we have big challenges too, how we'll be able to such important international matters, we will be able to discuss them. Trade union, thank you for your representation today. Associations of hospitals also, thank you. And thank you to all of you, each and all, and hospitals, heads of hospitals. I see one from Ventspils sitting here. Maybe it's Friday, you know, maybe something better. Could be some better plans. But thank you to everyone, to all the institutions, heads of institutions of the ministry, under the Ministry of Healthcare, colleagues, doctors, general practitioners, and everybody present here. Thank you, World Health Organization, for the support, for excellent cooperation we have with you and OECD. To you too, thank you. European Association of Healthcare Professionals of Doctors, thank you. And European New Doctors Association, you were here, you are here. And thank you, of course, to you, dear audience, who were present or online, and for being ready to listen to such serious problem discussions that we have not only in Latvia, not only in Europe, but also in the whole world. Thank you so much. Dear colleagues, I hereby announce the conference closed and presentations, recordings, and we will be able also to cut them into some videos and clips. They will be available on the webpage of the Ministry of Health Care. But let us strengthen their capacity for it not to be broken when everybody is going to download them.
Life balance. Thank you very much. It's Friday's night. Thank you.